Good morning. So one person's awake in this room. Good morning. Not so loud, I'm still sleeping. Everybody have a good night? Okay. So, for those of you who may not know me, I'm Susie Novus still, and I'm president of the International Myeloma Foundation. So, what I thought we'd do this morning before we get into all the formal presentations is I'd like to just tell you guys a little bit about the IMF, and I think you'll be surprised at some of the things I'm going to show you. How many people here have been to our website and floated around and got a lot of information? Okay, that's good. So let's see if I can show you something new. So first of all, this is a very special year for us because we're celebrating our 25th anniversary. Not Dr. Dury and I personally, but the IMF. So 25 years ago, the IMF was formed, 1990. And we've had a lot of milestones since then. We started our scientific advisory board in 1992. We held our first research fundraiser in 1992. First clinical conference ever for doctors treating myeloma patients was also in 1992. It was a really busy year. And then I went to this meeting in London called ISH, and I saw doctors meeting the professor. And I thought, well, why can't patients meet the doctors? And I was told that that was a terrible idea, that patients didn't want to become educated and they wouldn't turn out for something like that. And I said, really? So in 1993, we held the first Patient and Family Seminar. No organizations did that at that time. And it was right here in Los Angeles, and we had hundreds of people show up. So I felt like, na. See, I told you I was right. Being very grown up, of course. So the first support group, this is really interesting because the first support group was started by 4 women in a coffee shop in San Francisco. And today, we have support groups all around the world. So how many people here belong to a support group? Raise your hand. Okay, and for the support group leaders that are here, can you stand up, please? Okay. What's your group? Where's your group? Inland Empire. Where's your group? I'm sorry? Never heard of that place. Where's your group? Pasadena. Where's your group? Where's your group? San Fernando Valley. Did I miss anybody? Okay, let's give these people a big round of applause. They do excellent, excellent work. In 1995, we awarded our first research grant for multiple myeloma. It went to a gentleman called Dr. Atsushi Ogata, who was working at that time with Ken Anderson up in Boston. And we've been giving out research grants ever since, as you'll see shortly. And then we launched our advocacy program in 1997 because we know that patients need to be empowered and have a voice to make change happen. And change is happening thanks to our advocacy team, which you'll hear about later as well. In 2006, my dear friend and colleague Diane Moran started the Nurse Leadership Board. Many of you heard one of the members of the Nurse Leadership Board yesterday, and they do wonderful, wonderful work. In 2010, we held the first International Myeloma Working Group conference. The Scientific Advisory Board morphed into the International Myeloma Working Group, which now is comprised of about over 140 doctors from countries all around the world. In 2012, we launched our Black Swan Research Initiative, which you'll hear about a lot more from Dr. Dury later. And this research initiative has really taken off. In 2 short years, we are making a huge stride. We had held the first Chinese myeloma working group in 2012 and the first masterclass. And last night, for those of you who weren't here, our masterclass team is here with us today, and they've been here for the past week, and they'll be going home sadly tomorrow. But please stand up say hello to people who might not have had the opportunity to meet you last night. And in 2015, we morphed the GMA, the Global Myeloma Association, into the Global Myeloma Action Network, which is comprised of members from all over the world coming together to make change happen for myeloma patients around the world. So today, we're 25, and we've reached almost 400,000 people around the world, including patients, doctors, and nurses. So that's quite an accomplishment. We focus in 4 areas: education, support, research, and advocacy. So in education, how many people are calling the info line? That's Missy, Judy, and Paul calling the info line. 1, 2, 2. What's wrong with you people? It's free. They're really smart. So anytime you have a question, just call 800-452-CURE, and you can ask Missy, Paul, or Judy questions, and they're really, really incredibly well informed. They answer over 4,000 calls and almost 4,000 emails each year. So Patient Family Seminars, how many people attend a seminar? That's a trick question. You're all attending a seminar. So just in case you can't get enough of the seminars, there's one more that's going to happen this year in Stamford, Connecticut. So we're celebrating 22 years of doing these wonderful meetings. Kelly Cox came up with a really good idea several years ago, and he launched the regional community workshops. There's many of those taking place all around the country, and the ones in green haven't happened yet. So if you want to go to Ann Arbor, Richmond, Virginia, or Washington, D.C., hop on a plane and go to a regional community workshop. They're really, really great as well. So we are international, and we have lots of global initiatives. That's my wonderful colleague, Nadia Eckelbeer, who is the director of IMF in Europe and in the Middle East, and she is incredibly active. So these are all the places where Nadia has been holding meetings and collaborating with patient groups where they exist, and where they don't, she's doing them with all the members of the International Myeloma Working Group doctors. So there's lots happening all across Europe. The Myeloma Minute, how many people subscribe to the Minute? It's free. Every hand should go up. It's weekly information. Myeloma Minute is short bursts of important information, links to articles. It's really, really great. And for example, a recent topic was, can a longevity feast be the key to a longer life? There's an island, a Greek island called Ikaria, and these people there live to be well over 100. Part of it is they get up in the morning and they start drinking right away. Red wine. Okay? And a lot of them don't have clocks, and they eat all organic food and a lot of goat. I'm not really a big fan of goat, but I think that the wine is a way to go. And another one was, could a cancer drug value framework limit access? And of course, access to these, we have wonderful, wonderful drugs, but it's really a challenge for some people to get access because of the cost. So that's what our advocacy team is doing. You'll be hearing more about that. So just to show you how broad our reach is, the Myeloma Minute, in English, over 39,000 subscribers, and again, it's free. And then you can see in French, Italian, German, Spanish, and we have lots of other foreign language publications. And those are how many downloads so far this year. Publications, we have the Patient Handbook, the Concise Review, and our Understanding series. I'm sure many of you picked up Understanding series and all the booklets out there. They're great, and of course we translate them. We work with members of our International Myeloma Working Group to do the translations, and we have them in French, Italian, German, Spanish, Russian, Arabic, and Turkish. I'm particularly fond of the Turkish one. So as I mentioned, we are very, very proud to have these wonderful, wonderful doctors from China with us, and our faculty was Dr. Dury, Tom Martin, Dr. Krishnan, Joe McHale, who's here with us. Joe, where are you? In the back. What are you doing sitting way back there? Okay, baby, I'll try and do my best. And of course, Dr. Vesio. And the course was just fantastic, and they had a very tough test yesterday, and they all passed, and they're taking this really wonderful information that they gained here back to their colleagues in China. So our website, good news, this website, which drives me absolutely batty, we're scrapping it, and under construction right now is a brand new site, which is going to be wonderful, much more user-friendly. But nonetheless, we've had over 2 million visits to our site this year. And it's only, what month is this? I'm losing my mind. No, it's August, I know. So I'm sure that you'll be really appreciative of the new site once it gets up and running. One of the things that Dr. Dury started was this 10 steps to better care. And when you go there, there's a tab for patients, there's a tab for nurses, there's a tab for doctors. And these are the 10 steps. And you'll see how many visits and how many downloads people are doing, because this is an incredible tool for the entire myeloma community. So I encourage you to go there and also tell your doctor about this. Say, hey doc, have you looked at the 10 steps to better care? Because a lot of times you're seeing a doctor, that might not be a myeloma expert. You know, they might be, specializing in something else, but they also treat myeloma. So this is a very, very helpful tool. And as you know, knowledge is power. So web visits by country. There's organizations around the world, and yet everybody still comes to the IMF's website for information because we're the best. Let's face it. I'm not biased, of course. So Europe, Middle East, Africa, I think it's very, very impressive that we have such a broad reach because we're all together in this. Asia, Oceania, Latin America. It's really, really a testament to the hard work of my team, and I'm very, very proud of them. So we're on the web, of course. So we tweet, we're on Facebook, we have IMF TV, YouTube, we're blogging, webcasts. So, I think we should all put down our devices once in a while and just read a good book, but in the meantime, here we are. So ask Dr. Dury. You can submit a question. And it was really fun because not that long ago, this couple came out from Staten Island, support group leader and her husband, and she had a question. And I said, we're filming Dr. Dury today. So she went in and she asked Dr. Dury her question and was filmed. It was really, really fun. So if you have a question, submit it, and chances are Dr. Dury will answer it. Won't you, Brian? So again, here's just some stats on how active we are on IMF TV. Physician education, yes, doctors need to go to school too. So every year at the American Society of Hematology, that's the big, big meeting that's held every year. It's called ASH, and every year we do a symposium for clinicians. And our room size kept growing and growing and growing. And they're very strict, the fire code people. They come in and they, look to see if we were overcrowded. We always are, and last year we had over 1,000 people attending this. So these are doctors from all over the world who come and they listen to the members of the International Myeloma Working Group tell them all the latest information and advances in myeloma treatment and management. And as you will probably recognize some of the names up there, like Dr. Dury, maybe not, well, Shaji Kumar, for anybody who's gone to the Mayo Clinic, and the others are from Spain and France. So as I mentioned earlier, my colleague Diane Moran, you heard the nurse yesterday. Nurse Leadership Board is very, very important. They're really the key to making sure that you can tolerate the drugs and you can manage the side effects that are often common. So in the support department, we have our wonderful support group team there. Robin, Nancy, Kelly, Anne, and Sue. Each year, we hold a support group leader summit. Who here attended the summit? Okay, what did you think? It's great. Can you see yourself in the picture? Okay, good. So this was the 16th annual Support Group Leader Summit, and we're really grateful to our pharma partners for supporting this amazing event. So 100 support group leaders representing 70 support groups come together for a really intensive weekend, and they learn a lot from each other and from other speakers, and they take that information back to their group. So we're really, really, to all the support group leaders, big round of applause. We do a lot with support groups. We have quarterly conference calls. We have a Living Well with Myeloma. And again, we bring support group leaders to this meeting called ASH in December. Advocacy. Where's Taylor? Is Taylor in the room? He's probably out at the reg desk. So our U.S. advocacy, Megan, Taylor, and Lindsay, who's new, they really, really are doing an incredible job of ensuring that the oral parity drug bill is passed in every state, and they're almost there. Taylor has a graphic, and there's a few states left, but this means that people can get help. Taylor, I'm talking about you. How many states have the oral drug parity bill passed in? 40. Okay. How many states are there? Okay, so they're really, really working very, very hard. And there's two coalitions, PEAK and SPEAK. PEAK is the national and SPEAK is the state. So a lot of these bills are passed in the state, but then we also need to get them passed on a federal level. Am I correct? Yes. Okay, good. Okay, so I think everybody should get involved in advocacy because you have a voice and it's important that you use it. So don't forget to meet with Taylor and see how you might be able to lend a hand. So around the world, we've spread across the world. We have IMF Japan, Latin America, IMF Israel, and IMF Europe. And these are coalitions. We have an affiliate in the Czech Republic, Myeloma Japan, Australia, Canada, South Korea, better than North Korea, and in Turkey, especially now with North Korea. So the Global Myeloma Action Network, this is new. We started a couple years ago, and we are in all these countries. These are members of GMAN, and as I said, we get together twice a year, and this was the meeting that took place in June, and it's really wonderful that we're truly a global organization. Research, because we are on the brink, you heard Dr. Dury say starting cure trials, using the C word. It's amazing. So we've been giving out research grants, as I mentioned before, but we've given out 113 of these grants. And today, the IMF is the only myeloma foundation awarding junior and senior grants. This is really important because they have great ideas, and we need to keep bringing new people into the field. Myeloma is a very, very hot field to be in, but it's important to keep getting new people and junior people involved. As I was mentioning, the Myeloma Working Group has a summit each year. It's held at the time of the European Hematology Association meeting, EHA. We just held the 6th annual IMWG Summit, and it focused on the topics you see there: double refractory stem cell, genome sequencing, new drug approvals, cost of drugs. You'll be hearing more about that later. You might recognize a gentleman sitting in the back of the room, Joe McHale, and Dr. Dury, along with Ola Landgren and Antonio Palumbo. We do this thing called the International Myeloma Working Group Conference Series, Making Sense of Treatment. And it's wonderful. It's live streamed, and it's really fun to see these guys debate these top issues. So the last one was held in Vienna, and the next one will be held at the time of ASH. But you can go online and look at them. They're really, really they're entertaining, and they're very informative. Our Black Swan Research Initiative, I would suggest that you ask Dr. Dury about that. He'd be happy to talk to you about it more. And we truly are what I like to call one myeloma nation. If we could dim the lights, and I'm in Hollywood, roll it. The myeloma community is truly global. And we are one myeloma nation. No matter where you live, we're going to reach out and we're going to help you, and you're going to reach out and help us. We are all connected, and by being together and working as a common entity, I think we have a lot of power to make changes.
We brought together the doctors who were committed to help the patients. And so establishing and expanding that contact with the doctors, educating the doctors as necessary, is a key groundstone to build on to provide that education for the patients.
IMF is focused to empower patients affected with this disease. And it's well known that when you empower patients, when you provide them important information, when you provide them the opportunity to speak to each other, to interact, to learn from patients, to learn from experts, the outcome is much better.
Knowledge is power, and from the very beginning, empowered, informed patients do better. And once you start taking control of your life and your family, everybody starts feeling better. They feel like, oh my God, there is hope out there. I'm not doomed. There are therapies out there that can really put me into a good remission. And there's more stuff coming along, and there's tons of stuff in the pipeline.
My goal is to make sure that whoever comes to our seminars, they can be patients or friends, that when they leave the room, they have more knowledge, they have more peace, and they know that they are not alone.
When we organized the first patient seminar in Italy in 2003, that was a big success. And we had more than 200 patients, and that was the first one. Since then, we had every year at least 1 or 2 patient seminars in Italy.
It was really a breakthrough after the foundation of IMF Brazil. In the last 10 years, we have myeloma era pre-IMF and after IMF.
IMF brings to Czech Republic tools, education, experience, and also confidence that we are on the good track.
When there's a problem or we have a question, there's always go-to people at the IMF office in California. As a matter of fact, our Canadian patients who generally call us with questions, sometimes the questions are a bit complex, so I refer them down to the IMF hotline, and whether it's one of those amazing hotline coordinators or Dr. Dury himself will get back to that patient and answer the questions.
I'm a medical oncologist and I've been in the work.
So are there any other choices that would be common for you? We recognize that the IMF is the International Myeloma Foundation, that we need to work with everyone around the world. We need to make exchanges, and we need to be able to have the opportunity to go forward with all countries. And so it's very exciting that we have a rather robust program in many parts of the world.
The IMF continues to see the need to educate. And this is the good news. We have a lot of new drugs available for the treatment of myeloma. Patients are doing a lot better. And so there is a continued need for education to understand how to use the new drugs, which ones to use, which combinations are best.
It's time that we just come together as one myeloma nation, work together, and put an end to this terrible, terrible disease. Now, I know that it's a reality. We are going to start curing people with multiple myeloma.
Well, thank you, Susie, and I hope you enjoyed that video. It does highlight a lot of the activities that the IMF does, not just here in California, but around the world. It also emphasizes really two major takeaways from the IMF and meetings like this. So the first one that you saw emphasized a few times is knowledge is power. And the idea, obviously, is that you guys need to be informed so that you can talk to the doctor and understand what's going on and make sure the doctor understands what's going on and really have the best discussion possible to get the best care. And the second thing about these meetings is that you are not alone, and so obviously the IMF is committed to be here to help you, but you can see in this room that you can learn a lot from a lot of these other patients who are here. You heard yesterday that many patients here have been working well with myeloma for a lot of years, for 5 years, 10 years, 15 years. And so you should take the opportunity to connect with some of these longer living patients and find out what's their tip to be doing well and getting the best results. So in this first talk, I'm going to go over some of the basics of myeloma, the basics that you need to know about the diagnosis of myeloma and the monitoring of myeloma. The main thing about that is that the testing that you need at the time of the initial diagnosis is also a lot of the testing that needs to be checked for the monitoring to make sure, are you in remission? Is there a need for a change in the treatment? Is the myeloma under good control? Is the myeloma relapsing? And so it's important just to know what is the battery of the testing, what is the list of tests that need to be done, what do they mean, and how often should they be done. This is extremely important to have a plan for the testing and the treatment. So this is Manhattan Beach, by the way. I kind of like this picture. This is the good part about California, down by the beach there. Susie showed you that the 10 steps on the web is available to help, but actually it also helps us to understand which questions are the most important. And so you can see here that the questions about diagnosis and the tests that are available, out of 700,000, almost 200,000 are about the tests. People want to know about, well, which test should I be getting? And then if you go down to the bottom, you can see that a huge number of questions are about, okay, so I need to find some new drugs, some new trials. And we have a lot of information about new trials. So we track that so that we know which are the areas where we need to be really sure that we have good information, the best information to try to help you. And so one concept about myeloma, which was presented a lot, actually by one of Dr. McHale's colleagues, Dr. Maury Gertz, one of the doctors at the Mayo Clinic in Rochester, Minnesota. He always described myeloma as having weeds in the garden. So instead of having a beautiful garden with all the flowers growing great, the weeds take over, kind of like our backyard. You know, those weeds are popping up. And obviously the concept is that you need to get something to get rid of those weeds. And the thing is that you want to get rid of the weeds, but you do want the garden to come back. And so it needs to be a selective treatment that would allow you to clear the weeds, but then also have the normal bone marrow cells recover. And so the way that we look at this, when you have that first bone marrow test done, what we're looking for is, do you have a mixture of cells, so that when the sample from your bone marrow is sent to the lab, we're looking to see, does it have a mixture of cells with the white cell production, red cell production, the cells making the platelets, or is the bone marrow filled up with these cells over on the right here? These are the myeloma cells. So when you have a bone marrow biopsy, it's very similar to where if a woman has a breast cancer, you take that sample and then you see the tumor cells, the breast cancer cells. So this is the same. When you have a bone marrow biopsy, we're looking to see if you have the tumor cells, the myeloma cells, in an area which is, what we call focal lesions. When we see these on an X-ray, those are the plasma cells that are in the middle of what we would call a lesion, a focal lesion. And so we can see the numbers so that we look, what is the percentage? So instead of having this mixture over here, 10% or 30% of the cells are like this, just an area with a tumor nodule. And so those cells have different things that they do. But in the big picture, those are the cells that are causing what we call the CRAB features, C-R-A-B. C, calcium, R, renal or kidney, A, anemia, and B, bone lesions. And so those plasma cells which are sitting in your bone marrow, they're causing some problems right there in the bone marrow, but they're also producing a protein that comes into your bloodstream and can damage the kidney. If the myeloma is damaging the bone around the marrow, then it can lead to the release of calcium into the bloodstream. So those cells in the bone marrow can lead to an increase in the blood calcium. The protein can cause kidney damage. The cells in the bone marrow interfere with the functioning of the normal marrow. So the normal red cell production is reduced because the myeloma cells are inhibiting or displacing. It's probably not just a physical problem. A lot of chemicals are produced and other cells interfere with the production of red cells. And so you get an anemia which is proportional to the amount of myeloma in the bone marrow. And so we are very, very keen to know what is the hemoglobin, because if the hemoglobin is going down, then we're concerned that the myeloma is going up. But vice versa, as you respond to the treatment and we get rid of the myeloma, the red cell production will go up and the anemia will go away. But the key thing about myeloma is that the myeloma cells grow and trigger the bone cells into being unbalanced. And so there's too much damage to the bone and not enough bone healing. And so you end up with what we call bone lesions, which is basically areas of bone destruction. And so these lead to what we call the CRAB criteria. And this is the key feature to identify myeloma that needs treatment at the beginning of the disease, but it's also what leads to a definitive need for treatment at the point of relapse. If you're going along and things are going great, if you're starting to develop CRAB features again, then maybe that means we need to change your treatment, give you new treatment. Now, more recently, we have been keen to consider starting the treatment earlier. We want to not let you develop the CRAB criteria. We want to avoid the CRAB criteria. And this has led to something which actually Dr. McHale is sitting at the back called slim CRAB, the small CRAB. And these are things that are happening before you develop the CRAB features. And Dr. McHale called them a slim CRAB because it means that the serum free light can go up. There can be an increase in the bone marrow plasma cells. And there is a change in the MRI and the imaging. And so this is slim CRAB. There's also new CRAB. So we've got CRAB, slim CRAB, and new CRAB. But these are the things in this box right here that can happen before you get the typical CRAB features. And what we know is if one of these things is happening, that you're likely to have a problem within 9 months, a year, certainly within a year and a half. And so if we want to kind of get ahead of things, if this is happening, we could and should now consider start treatment when these things are happening. If the bone marrow plasma cells have increased to 60%, usually myeloma will be obvious at that point. But occasionally it can get to 60% and the myeloma is not really developed yet. But now we're saying if it's 60%, really we better get started with the treatment. And the same with the free light. Normally if the free light ratio is more than 100, oftentimes a patient will already have myeloma. But if they don't, chances are it's going to be really soon, and we should start to think about treatment. And then the same with the kidney function, using a more sensitive test for kidney testing. But the key difference in the new approach is to look very closely with MRI to see if there are lesions building up. And in this new definition, if you have more than one, which basically means 2 or more lesions on the MRI, then this indicates there's going to be a problem and you're going to develop myeloma, and this would be a good time to think about starting. We're also looking more closely with imaging across the board, and so we can use PET CT scanning. If you have a positive PET CT scan, that basically is B of the Crab criteria. Those are bone lesions. That means that we need to treat. A positive PET CT means that there is a hot spot where the myeloma has taken up the sugar, which is injected, but also around that, the CT is showing bone damage. So there's some destruction. So a positive CT means positive uptake and some evidence of damage around the hot spot. We also use whole body low dose CT, and this is a newer technique where we can scan the whole body and look for tiny lesions. If we find lesions which are more than 5 millimeters, the tiny ones, if you've ever looked at x-rays, you can see that the x-rays are not even, and so you can get little bits of holes that show up. But if they're beyond a certain size, then that means that there is an area of damage. So these imaging techniques are more and more necessary, and one of the issues that's coming up is that you need to get insurance coverage for those, and we're happy to talk about that a little bit, so that to justify and to get the insurance coverage for those. So this is just to illustrate in a little bit more detail how the myeloma is creating problems and how it is contributing to the abnormal test results that we monitor the disease. So as it starts out at the top there, you can have a small lesion which maybe is not damaging the bones. And we used to always do the interactive, what we call the audience response system at these meetings, where we asked you how many patients had actually bone lesions when they first were diagnosed. And maybe we can ask that. My question would be the opposite. So how many patients, when they presented, where their bones were fine, they were not having any x-ray or problems, how many patients were like that? Yeah, quite a few. Normally it's about 25–30% of patients these days are diagnosed before the bone damage, where the lesions are small. There is a spike. The myeloma cells are producing a protein which goes into the blood. It could travel and it could be starting to damage the kidneys, but the lesion is small. They may have a little bit or no anemia, no bone damage. Now at the bottom, as the myeloma gets bigger, then it starts to damage the bone, which could cause anemia and bone damage, and then you get a much bigger amount of protein in the blood or urine. You could have some calcium in the blood, although that's much less common in the US now, because we normally pick up myeloma before the blood calcium goes high, and also before there's much in the way of kidney damage, actually. But this is how this is all happening. So the damage is related to the amount of the myeloma. And these are the tests that we use to get a handle on this. So the tests that you would be getting initially and then on a periodic basis, usually once a month to begin with, and then maybe every 2 or 3 months later on, you obviously would get what we call a chemistry panel, which is checking your kidney function, your blood calcium, and the normal body chemistries. You would be getting protein testing. And this is very, very important. When we talk about knowledge is power, this is the bit of knowledge that you really need to know. You need to know, what type of myeloma do I have? This should be top of your list. What is my type of myeloma? what is my type of spike? Do I have IgG or IgA? Which would be showing up on SPEP. It would be serum protein electrophoresis, which I'll show you in just a second. So what type of spike do I have? Is it IgG, IgA? That's what's called a heavy chain, but sometimes there's only a light chain where it would just be either kappa or lambda, and this would show up in the UPEP. The light chains are lighter, smaller, and they pass out into the urine. And so that's picked up by doing a 24-hour urine collection, which I think probably most of you have had done. So who's had a 24-hour urine protein done? Yeah, most all of you. I am involved. I actually am amazed, and your knowledge is power. I'm involved with a registry where we track the practice in the community, and so we ask the doctors, you know, did you get a urine protein test? And some of them say no, and we're like, what? You didn't get that urine protein. And so you need to be on top of that, because the urine protein can cause kidney damage. And so getting that urine checked initially is very important, and getting it checked from time to time along the way is also really important. The other is to check QIG, which is the quantitative amount of the IgG or IgA, and then IFE is immunofixation. That helps us to tell the type of the protein. It also is a test to tell the depth of the response. And so if even using this IFE, the spike is gone, that's when we have a complete remission or a stringent complete remission. So when this IFE test is negative, that tells us there's been a fantastic response to treatment. Down at the bottom here, we have to check your blood counts to see if the myeloma buildup has reduced your red cell production and you're anemic, or if you have low platelets or low white cells. Over on the right, the chemistry does show the kidney function, but the key thing is the bone marrow test. Unfortunately, I'm sure all of you have had a bone marrow where we are interested in the percentage of the myeloma cells, but very, very important is this chromosome testing, which includes something called FISH testing. And this is not like a smell test to see if it's turning bad. This is a fluorescent test, fluorescent in situ hybridization. Basically, we stain the chromosomes with a particular color, which I'll show you on the next slide. And then beyond that, we also are doing the x-rays and scans. So this is just to show you a little bit some of the details. This is this SPEP test over on the top left there, and that is the serum protein electrophoresis or urine protein electrophoresis, where you can see the spike. The spike is the amount of the protein which is proportional to the amount of the myeloma. So we see that spike on there, and then that's something on the report. If you look at the bottom, it will say monoclonal protein. It might say it's 1.2, and then it's going down to 0.6 or to 0.2. These are the numbers that we're tracking to see the size of that spike. Then we don't do a bone marrow too often frequently, because we know you have the myeloma, and we don't need to be doing that all the time. We do need to be checking your x-rays or the bones in some way to see if you have those lesions on x-ray, MRI, or PET scanning. These days, we are using more sensitive imaging, particularly the PET scanning, where you get an injection of sugar, which is labeled, and so when myeloma is active and growing, it takes up sugar, and we can see it. The color, you can change the color. Over on the left, I like it because it's a cool yellow color, where the sugar is taken up, and it shows yellow if there is a sugar uptake. Over on the right here, if there's sugar uptake, it shows as a dark spot, as a black spot. In the middle is MRI. What you need to know is that basically the lesions show up on either one. There's some differences, but you can see here there's a bunch of dots in the PET scan, and then there are also a bunch of white areas in the MRI, so very similar. You can see the same lesions on a PET scan. You can also see it on the MRI. The big difference is that the PET scan stops taking up the sugar pretty much right away when the treatment is starting to work. With the MRI, it can take 6 months, 9 months for the MRI lesions to go away. And so if you do an MRI after 6 months, it still looks pretty much the same. So it takes a long time for the MRI to get better. And so this is something very important to be aware of. For the PET scan, it shows the myeloma. It can get better very quickly. It can also show lesions all around. These different arrows are showing you that there can be spots in different places, which is kind of scary, I have to say, but it is really important to make sure that all those spots are going away, and over time that there's not a new spot that might have cropped up. And so imaging is very important. Those lesions that are in different spots, we need to keep track of them. We need to make sure, are the x-rays negative or positive? What kind of imaging are you having done? The thing about the imaging is that it's going to be repeated. So whatever test has been done at the beginning, that's what's going to have to be done later to see if you're getting better. So if you had a PET CT scan, then you're going to have a PET CT scan later to compare. If you had an MRI, you're going to have a follow-up MRI to see if it's getting better, because otherwise we don't have the correct comparison. So this is something to talk to the doctor about. What type of x-rays or scans are we going to do, and is it going to be possible to get those regular follow-ups to see how I'm doing? This is just to explain some of the testings. That pattern that I showed you where you have the spike, so we use a calculation. It's actually what we call the area under the curve. We calculate the area, and then it gives you a percentage, and then we convert it into the number of grams or milligrams. And so this is how we calculate the size of the spike. Over on the left, it also allows us to calculate the amount of the albumin, which is another protein in your blood. So as the spike goes up, the albumin goes down. And so this is very helpful to see this seesaw. So as you respond to treatment, the spike will go down, the albumin will go up. And that's the basis for part of the ISS staging system. The staging system is stage 1, the albumin is normal. Stage 3, the albumin is low because there's more myeloma. At the same time, the beta-2 microglobulin is going up. So ISS stage 3, the beta-2 microglobulin is high and the albumin has gone down because there's more myeloma. And these are the calculations that we use. More recently, we can use the heavy light test to monitor the myeloma. And you heard a little bit about that yesterday. We can use the free light and the heavy light. Free light to check the light chains in the blood, and also the heavy light to monitor the IgA or IgG. And we're going to be using those more to track the myeloma in a very sensitive way. This is the FISH testing, and this shows you that when we stain the chromosomes, we can stain them different colors. So that when we say there's a problem with chromosome number 17, it's the blue one. So we can see you should normally have 2 complete blue ones. So if part of it's missing, or all of one of them is missing, then that's what's called 17p minus. Now in these chromosomes, P is the top part and Q is the bottom part. So when we say 17p minus, that means the blue one, the top is gone on one of them. So it's a visual test. So you need to have someone who knows what they're doing. They're looking down, they're like, oh, is it the blue one? Is it missing at the top? You can see there's some observer error possible. So it's one of those tests. There's some tests where there's observer error. There's some where there's a number that just spits out of the machine. In this case, it's the observer that needs to be looking. You can also see that every cell could have the blue one missing, or maybe some of the cells might have the blue one missing. Or you can also see 414, what that means is number 4 is green. 14, if you track along there, 14 is red. So if you have a piece of a green one and a red one, that means that it's 414. The 4 has joined up with the 14. So you see in the middle there, there's a red dot and a green dot. That means it's 414. Those chromosomes have come together. So if you see a green and a red, then we know it's a 414. So it's a visual thing. Over on the right, you can take the myeloma and see which genes are active out of all of the genes. And you can focus on 70, which is what the team in Little Rock did with Bart Barloghi. And he found that using the 70 gene profile, red is where they're active and green is where they're shut off or low. And he found that the active ones can indicate if the myeloma is more aggressive and into this high-risk group. Okay. I hope this is not too much information. Are you okay so far? All right. So, the two tests that give you the ISS staging system, this is the international staging system that actually the IMF developed in 2005, is based on the albumin, which can go down, and the beta-2, which goes up with active myeloma. And then if you look at the pattern, if you have ISS 1 and the FISH testing is normal, you can see those are the patients that are doing great. See that blue line there? The blue line is indicating that patients, over half the patients are doing great at 10 years. So those patients here who are saying they're doing great at 10 years, they're probably on this blue line right here. This is just to show you that as we're moving forward right now into treatment for myeloma, we are increasingly distinguishing from the earlier disease. We want to make sure, is it MGUS, which is the earliest? Is it smoldering, and there's several people right here in the room with smoldering, or is in this early active stage in transition that we need to treat? And I'll talk about that a little bit more with the Black Swan project, how we're interested in those red areas, the transition points to more active disease. But for all of you, the most important thing is, and as you talk to people, you'll realize that everybody's myeloma is a little bit different. Somebody could have every CRAB feature. Somebody could have the calcium is increased, their kidneys are, oh yeah, this is helpful, thank you. This other pointer is not working. I'm glad somebody noticed that. See, Susie noticed. This is very good. What? So every patient is different. So you can have IgG, IgA, there's also rarer ones, D and E. You could also have no production at all, which is called non-secretory. So few patients have that. You can have, as I said, all the CRAB features, 1, and now it could be none, and then you could have slim CRAB. Or we would be very interested in how old are you? Are you able to have a transplant? What is your stage? What does that FISH testing show? Does it show those dots where there's a piece of blue missing or where the red and the green are coming together? And what does the PET scan show? And so you can put all of this together and you create what we call staging and prognostic factors that we use as a basis to think about treatment. And this is what you're going to be hearing from Dr. McHale and Dr. Jean-Luc Harasso, where they're going to say, okay, based on these, we can see different results, different response, different remission, different survival, based on these different things. The staging, the FISH testing, and you can also look at the chromosomes, looking at whether there are extra chromosomes, which is called trisomies, which is a good thing as it turns out. Why would that be? We really don't know, but it is a good thing. Loss, on the other hand, is not so good. So we look at those sorts of things. And then we move forward to say, okay, we've got this all figured out. We know your CRAB. We know those prognostic factors. And now we need to talk about your treatment. And this is what you're going to be hearing about mostly for the rest of the morning. Is it good to use a 2-drug combination? Maybe we should be using 3 drugs, or maybe use that extra drug later. Should you have a transplant? Maybe, no. What is the impact of those prognostic factors? Then we need to think about what are the side effects. This could produce a great response, but what about this? I'm really worried about the neuropathy. What about this DEX? How much DEX do I need to take? Actually, this is a really good question because there are still doctors who use DEX for the 4 days. Is there anyone here who got the treatment where the DEX was given for 4 straight days? Yes. Tom over here. He got the old 4-day protocol. So all of the rest of you, you're just taking the DEX for 1 day a week, is that right? Yeah? Okay. That's an amazing shift. Interesting for us to see because Mike Katz was actually the one who, well, I had given him 1 day a week DEX and he did great. And so he knew personally that he could push for that it was sufficient. And then it really led into the ECOG trial where we showed that it could be a good treatment. Then there's a risk of blood clots, and that might tell us that we don't want to use thalidomide or Revlimid. And then we're always worried about infection, and we'll talk about that a little bit. But one of the main things that I think is incredibly important, and it's part of the knowledge is power idea and also you are not alone idea, is that when you're diagnosed, this is really crazy, you know. In the old days, patients would go to the library and they'd turn to page 42 and they think, oh my God, this is myeloma. Holy smokes. Now you can go to the internet and you can find all kinds of crazy information. And so it takes a while to understand what this could possibly be. But it also, despite what the words might say, it takes a while to adjust and set what are going to be your plans, to know what you can expect, and really get some confidence that the treatment is going to work in your case. We can say that the response rate is 90%, and you're thinking, okay, well, am I in the 10% or the 90%? You know, it takes time to know that the treatment is working for you and that your expectation is that you can do well for 5 years, maybe 10 years, maybe longer. So it takes time to make this transition from being absolutely terrified to get this hope that we really want you all to have when you leave this room today, that myeloma is treatable, that there's a lot that we can do, there's a lot of support available, and we're here to help you. But I love this picture because hope does not come overnight. And this little girl, she's trying to get the hope to take a hold. And she's protecting the flame from the wind. And it just takes nurturing. It takes time to get that confidence that the treatment is working, and over time that you can return towards some normal things and return to a normal life. And part of that normal life is to make sure that you get enough sleep. I've always liked the idea that if you sleep right, that you might actually lose weight. And I believe that's because when you're sleeping, you're not eating. There could be another way it works, but I'm not sure. I think that exercise is really important for myeloma patients. Your bones can be fragile, and the key thing is it's very important to get back into some degree of exercise to keep your bones strong and to really recover and be able to go on trips. But do know your limits. If you've got an area where there's been a problem, check that out for sure. There are always lots of questions about food and drink. And people think, well, maybe I got myeloma because I ate Kentucky Fried Chicken too much. I don't know. But the opposite is certainly true, that people have this strong feeling that they will do better if they eat better. And I think that is certainly true, and I do believe very strongly about that. It's not going to get rid of your myeloma, so I'm not saying that, but it will certainly help you to be healthier and to do better. And so eating real food, this is a fantastic book, by the way, by this lady here, and cooking using real food. And I've been writing recently about this place, Acaria, where people live to be 120 years old. I've been pretty interested in that. I thought, well, two things really. How do they get to be 120? And then number two, are they happy at 120? And there are a lot of tips, and this was a pretty interesting one where Icaria is a blue zone, and there's 7 of them right now identified where people can live to be 100, 120, and the question is, what are they doing that we're maybe not doing? Well, mostly it seems like they're not living in a big city like LA or New York, but there's a lot to be learned by what they're eating. I think it's not all about what they're eating. It's about having some relaxed life, not paying attention to the time as much, and actually having fun. And so I've written a little bit about it, and you might be interested to see that. The key message is, if you're eating something and your grandmother would not recognize it, quite possibly it could be a problem. Yes. Yes, there is. It is where the, sorry? It's Loma Linda, yes. So that's what I was joking about a little bit. In Loma Linda, the area where people are very strict vegetarians, and they have a very strict protocol, which is it's the one blue zone where they are incredibly strict about their diet and their activities, where all of the others, sorry? They do exercise, they do, yes. I maybe skip over all of the details about how to stay 100% healthy. Susie is convinced that I'm not implementing all of them. There's a lot of questions, and I'm not going to answer them right now, about different supplements. Omega-3 fatty acids, fish is good. Green tea has antioxidants and flavonoids, and then there are lots of supplements that we can talk about that may help for neuropathy. Yes. Yes. So this lady is immediately pointing out something which is correct, is that there may be a problem in taking green tea along with Velcade. It maybe interferes with the absorption or the distribution of Velcade, which is sort of scientifically maybe yes, maybe no. But my suggestion is that you don't take the green tea on the day of the Velcade shot. It's a simple way to deal with that, okay? Because it's a matter of 3 to 4 hours probably. And so just to avoid that doubt, it is a good idea to skip the green tea on the days of your treatment with the Velcade. Even although the connection may or may not be 100%. I think that, as I've been saying, that when you get the diagnosis of myeloma, it's pretty scary, but nonetheless, you need to try to get back to the situation where you are more on an even keel and work towards reducing stress as much as possible day to day. But the final thing I want to say about these meetings is that you gain so much from each other, and the support of, and many of you are here with your partner, who is many times helping to guide your therapy. And so that teamwork and that support is really important in your personal team, but also in the larger team and in your support groups, and in this kind of a meeting, which is even larger, to get the encouragement and the support to do the very best. And it's pretty clear that that knowledge and support will allow all of you to do better. And so with that, I'll finish. Right now, I'll just point out that the black swan here, I have them kind of in the dark. But later on, I'm going to light them up so you can see all about that. Thank you very much. So I don't know if we have time for some questions. We do? Okay, yes? So if we do, Joe and Bob, I think you're here. If you want to come up, handle some of these questions, help me out, especially about diet and exercise. I know that I know that Joe has probably been running already this morning. Is that right?
You're good on the diet, Brian. It's the exercise that.
Come up here.
Yeah.
Okay.
Well, go ahead.
All right, we got one right here.
You mentioned whole body low dose CT, and I'm wondering on the West Coast what facilities have it. Is it common?
Well, increasingly, most facilities do have these machines now. Joe, do you want to comment on that? Do you have a whole body low dose CT facility?
Yeah, we have that accessible at Mayo, although I must say we haven't really fully adopted it yet. I think a lot of places are still adjusting exactly how it's done, so I think the more conventional, whether even it's just initially basic skeletal survey and then ultimately an MRI or PET has been primarily the way we've gone.
Right.
No
So as far as your standard protocol, do you still do a skeletal survey to start with?
Yes, so we do skeletal survey to start with because it's cheap, easy, and if specific lesions are identified, we may not need more imaging than that.
Right, so
on the
but
other
if
hand,
that's negative, then you'll go to...
We'll probably, depending on the patient's circumstances, if they meet a smoldering criteria or if there's concerns about certain areas, then we'll probably do an MRI. Or potentially a PET.
Yeah,
It'll just depend on the circumstance.
Right. So the whole body low dose CT, I've talked to Bob about it. I mean, there is one at Cedars, but it's difficult to access right now. Yeah?
You can do it. It's, I think there's some issues with the radiologists are having kind of issues getting they get the whole scan of the whole body, and then how do they read the heart and lungs when it's not done correctly? You're kind of looking at the bones and not really imaging the heart or the lungs like it's supposed to be. Right. So there's some kind of issues with it. But
right.
Usually, like Joe said, we do the bone survey and then do PET scans and MRIs in select cases.
Right, right. Okay.
Right here.
Post the transplant, do you find that running any of the diagnostic tests again are beneficial? Do things change? Is it worth doing any of the diagnostic tests again sometime after transplant?
I'm sorry, I missed the first part of that. Testing after transplant?
Yeah, the diagnostic testing like FISH testing or other testing, do you find that there are any changes?
Right. So to assess transplant, you're going to be hearing about that from Jean-Luc Harrisseau. So the follow-up time point after transplant is 100 days. And so the question is, what testing would we do at 100 days? And mostly we would redo everything. Obviously the bone marrow, we want to see the percentage. So do you routinely repeat the FISH on that 100-day test?
We do. We basically plan to do FISH every time we're doing a marrow. But to be honest, a lot of patients now with great induction therapies that you'll hear from Dr. Harrisseau, as well as a transplant, most patients have such a minimal amount of plasma cells by that point that the FISH testing is not done.
It's almost irrelevant because there's nothing to test.
Yeah, what's probably going to be more relevant, I'm sure we'll discuss a bit more today, is the notion of minimal residual disease. And that's probably the more important diagnostic test at that time frame to help understand how deep someone's complete remission really is. Meaning, by simple tests, it might look like the disease has disappeared for the time being, but there still may be some residual disease that potentially could influence what we do. So we're typically doing now MRD testing at day 100 after someone has had a stem cell transplant to evaluate what next steps we should take.
Right. So we repeat, obviously, the blood counts, the chemistry, all that kind of stuff, and then, as I was explaining, you would repeat whatever imaging so that you can compare.
Okay, so we have 5 minutes left in this session.
All right.
Don't worry, we have all day.
Okay.
So, next question.
Okay.
Thank you. You were talking about giving sugar when you're doing a PET scan.
Right.
Is sugar something you should avoid when you're dealing with multiple myeloma, or try to reduce the amount of sugar?
This is a controversial point, and many times patients ask about that when I'm explaining the PET scan. They're like, okay, so this is where the myeloma is taking up sugar. But really, we have virtually no data that sugar in the diet really triggers the myeloma. What we know is that sugar is trapped within the myeloma cells by getting phosphorylated, but really we don't have any data that extra sugar will trigger the myeloma. Although, I mean, there is some data, and there are even some data that using diabetic medicine can be helpful in myeloma. But I would say that we don't specifically worry about that.
Okay, next question.
Dr. Dury, how do you identify the 3 separate stages of myeloma?
The stages, well, with this ISS staging, it's low beta 2, higher beta 2, and then high beta 2 with a low albumin. So those are the 3 stages. And then with the system that I developed years ago, it's based upon the different factors like the extent of the bone disease, the anemia, more linked to the CRAB criteria. Right now, I didn't show it here, but we're using a revised ISS where we use the albumin beta 2, the FISH testing, and then also LDH, which is another chemical in the blood. And so we use those things to classify into the 3 stages.
Which I think I entitled Bliss.
Bliss.
Oh, you're
Bliss.
always good with those.
Bone marrow, fish, LDH, and then the ISS staging.
Bliss. Okay.
Excellent.
All right.
Okay,
Slim crab and bliss.
We've got
okay.
We've got 2 minutes.
Just being at the IMF Patient Family Seminar is bliss. Am I
Okay.
right or am I right?
One last question. We got 2 minutes.
Right here.
Okay.
You mentioned diabetic medications. Are you talking about controlling the DEX rise, or are you talking about insulin for a true type 1 diabetic?
Yeah, I don't want to get into in some detail, but it's actually the oral by mouth anti-diabetic agents have been used as a treatment for cancer, as a matter of fact, with this idea that they would reduce the availability of sugar. There is some data on that, but really very limited, all right?
Okay. Thank you, gentlemen.
Okay. Thank you, guys. Thank you. So Dr. McHale is next. We're very, very pleased to welcome back Dr. McHale. Dr. McHale was kind enough to come out here at the beginning of the week to help with the teaching for our Chinese guests. And so it's especially fantastic that he went home to do a clinic at 2:30 in the afternoon, and now he's come back again today. So very, very pleased to welcome Joe to talk about the treatment for patients who may not be eligible for transplant. So please welcome Dr. McHale.
Thanks, Brian. Thank you. Thanks, Brian. It's always a pleasure to be here. I very much enjoy spending time at the IMF. Actually, just last month, as you know, I had the privilege of doing one of the patient IMF meetings in Sao Paulo, Brazil, with about 600 patients. We packed the house, and it's just a privilege for me, and I'm not saying it just to get brownie points. I give talks all year long. I know, like Dr. Vescio and Dr. Dury, probably over 100 talks a year, but the ones I give to patients are particularly enjoyable to me, because this is why we do what we do, right? It's for you. This is going to be a very serious talk. I do not want to see any smiling or any laughing, consistent with my character and with the way I approach things. This is serious business here. So we're going to talk a little bit about initially treating patients with multiple myeloma, and what I'm going to try to achieve in the next 20 minutes with you is as follows. We'll talk a little about when we initiate treatment for myeloma. And we've talked, Brian has already shared with us a little bit about the notion of initiating treatment, but it's such an important point. Myeloma is a very unusual cancer in the cancer world, that there are people who are walking around, maybe even in this room, who have myeloma, but we're not treating them. And it sounds a little counterintuitive, but for myeloma, this is an important phenomenon. There are people who do not necessarily need treatment. They get what I call my favorite treatment, nada, right? Okay, that was a joke. So like, thank you. All right, thank you for the one person who clapped. So, but nada therapy, as I like to call it, is great therapy because its cost profile is quite good. People tend to be very compliant with it, and there are very few side effects. So, and I don't say that to joke per se about the disease, but there are some people in whom we might just say, let's wait. And we all have patients in our practice who have, I think of several in my practice, even a few I saw this week, who were diagnosed with myeloma over a decade ago and still are on nada therapy. And that's important to note. We'll talk a little bit about risk stratification. That came up with the excellent question regarding how do we risk stratify patients or how do we stage patients. I mean, frankly, at the end of the day, there's two stages of myeloma. The stage that needs to be treated and the stage that doesn't need to be treated, right, in many respects. But we'll talk a little bit about how that factors in. And then we'll, instead of me just going through every study that's ever been done for patients not eligible for transplant and turn this talk into Charlie Brown's teacher, wah, 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 and the following, like when you go to our medical meetings, that's basically what happens. The doctors stand up and say, let me go through the 302 slides I've prepared for you today, and the following study demonstrated, and the following study, and after a while, all the curves blend in together in your brain and you've lost it. I'd rather just think with you about what are the hinge points, what makes me want to start a patient on a bortezomib-based therapy versus a lenalidomide-based therapy, or maybe even now in some respects carfilzomib and some of these other drugs that we're talking about. And then hopefully, finally appreciate, this is the objective that's sort of the let's hold hands and sing Kumbaya moment, let's appreciate that really, although Dr. Harousseau will be focusing on patients going to transplant and I'm focusing on patients who don't go to transplant, to be very honest, the difference between those two groups is limited now, and very often people are treated similarly whether they're going to transplant or not, and I'll explain what I mean by that as we go. So even though, as you see here, we still, generally speaking, divide patients into transplant eligible and transplant ineligible, their initial therapy can often be quite similar, and I'm going to be focusing on this first purple box in addition to the other things later. Oh, the other pointer works better? There we go. Oh, everybody? Ooh. Yeah, I got to make sure they stay awake. Okay. Smashing. So previously we really defined myeloma in almost three categories. There was this thing, and there is this thing called MGUS, or monoclonal gammopathy of undetermined significance. It was actually coined at Mayo Clinic by Dr. Bob Kyle, who helped recruit me to Mayo. So I'm very grateful for him. He is an outstanding speaker for those who have heard him speak. He sounds a little bit like Walter Cronkite, right? So when you become a myeloma doctor, you have to be able to pronounce monoclonal gammopathy as Bob does, right? So it's monoclonal gammopathy of undetermined significance, right? So if you can do that, you can apply for the job, right? But the bottom line here is that these are individuals who obviously have an abnormal protein in their blood from a limited number of abnormal plasma cells in the bone marrow, but not enough that we need to treat them. These are the people we treat, if you will, with nada. I tell patients like a little bit of dust in the corner. It's there if you look for it, but if we didn't look for it, frankly, it's not affecting the room, and you'd say that the Sheraton has a nice clean carpet here and there's no need to get a vacuum cleaner, right? At the other end of the spectrum, people have true myeloma where they're being affected by the disease, as you've heard already. And then in the middle is this smoldering business. And you've been hearing already that we've been talking about this issue of slim crab. We used to say the only reason why you would treat someone is if they already had damage, or what we call crab, the calcium elevation, renal insufficiency, anemia, and bone disease. Well, we added 3 criteria to this in our International Myeloma Working Group, hosted by the International Myeloma Foundation. And we came up with these 3 to add on to these 4 because, as I described to patients, if I see someone running towards a cliff, do I really have to wait until they're falling down the cliff to know that they're going to be in trouble? No. So these are 3 indicators that someone is getting really close to breaking a bone or to damaging their kidneys or to having other problems with their myeloma. On the other hand, if the cliff is 3 miles away and it's a beautiful day and someone's walking really slowly, I might not have to stop them. So we've tried to identify 3 things. If someone has more than 60% plasma cells in their marrow, light chains of what we call involved over uninvolved. As you know, people either have kappa or lambda light chains elevated, so it's the involved one over the uninvolved one over 100, or if on the MRI we find more than one abnormal spot, then that indicates that they have active enough myeloma that you should treat them. Don't wait, because if we do wait, they're likely going to come into damage. And if you're going to treat patients, then we say, well, is autologous stem cell transplant part of the plan here? And if the answer is yes, then please stay for Dr. Harousseau's talk in a few minutes, and he'll fill you in about how we approach the transplant side. I'm, on the other hand, going to spend the next little bit telling you about the non-transplant side. And again, it's not that we want to deprive people of stem cell transplant, but we've come to appreciate that transplant can be a tough process, and there's some people who would not be eligible for it. Not that we're ageist, but in general, when people get to the age 70 or so, we know that it's going to be more challenging. And I don't want to be prophetic. There's some myeloma doctors who are claiming that transplant is going away. I actually don't believe that. I still think there are a lot of patients who benefit from transplant. But there may be a group of people in whom we're transplanting less in the coming years, because we say we have all these other options. Do we want to go through a process that unfortunately takes you out of work for 3 months, that very often requires a hospitalization, that you can get quite sick with? Thankfully, it's quite rare now for someone to be so sick to die of a transplant. That's not routine, and we're grateful for that. But there's still a lot of challenges going through transplant. So there may be some people in whom we do it less, but transplant will still be, I think, a very valid option, and that's obviously in support of what Dr. Harousseau is going to share. But I'd like to think about those individuals who, as I say, generally speaking, are 70-ish or older, and how is it that we approach their initial therapy for their myeloma? Well, as I say, I could go through Charlie Brown's teacher here and just go through all of these studies, one after the other. I don't want you to notice anything on this slide apart from the fact that as we've gone from some of the older studies, brilliant studies, some of these that I know Dr. Harousseau participated in France, but as you generally speaking look down this column here, we start to see that as we've gone, we've gotten higher numbers. We've gotten more patients into remission than we'd had before. We have patients living longer than we had before, and that's a very encouraging phenomenon that we're grateful for. And similarly, we've started to see that survival rates, 3-year overall survival, when I sound like the old man now, when I was a medical student, but when I started my training and became interested in myeloma, I partly became interested in myeloma when I was an internal medicine resident, and I got a phone call from the emergency department that there was this young guy who had been playing hockey. As you probably know, I grew up in Canada. Any Canadians in the crowd? Dude, not one? Honestly? Wow. Susie, I think you need to order some maple syrup for lunchtime, all right? Can you do that? And he was playing hockey, and he had this really bad back pain, and it didn't make sense. And sure enough, this poor young man had a spine riddled with holes because of myeloma at the age of 25. Well, it turns out he was my classmate from high school, and he's still with us, and he's still doing really well. And I'm a little bit older than 25. So, but in those days, it was very unusual for us to think that myeloma patients could live more than 2 or 3 years. And now we're seeing, obviously, a dramatic change in that. We're grateful for it. So one of the key messages that I want to share with you is firstly that MP, or melphalan-prednisone, which we used for many, many years in myeloma, is really not the standard of care anymore. We can better melphalan-prednisone by either adding thalidomide or bortezomib, or the V for Velcade. But I'm going to show to you that even now, I would suggest we've gone beyond that. That melphalan is not historically something that we're using up front. Even though we see these what's called ORR, or overall response rates, and complete remission rates, we're seeing really fantastic responses when we add these agents like bortezomib or thalidomide to melphalan and prednisone, but we're starting to come to appreciate that maybe we don't even need the melphalan up front, and we'll talk a little bit about that. So for many reasons, most initial strategies now don't even use melphalan. Well, why is that? Well, I'll give you 4 reasons why. In general, we're not using it. And that's not to say if you've been given melphalan, you've been given the wrong treatment. It's to say that the field is evolving in such a way that we're moving away from initially using melphalan. Novel agents, and this is an interesting phrase, but basically refers to these newer drugs, which sometimes I think of as the big five. Thalidomide, bortezomib or Velcade, Revlimid or lenalidomide, carfilzomib or Kyprolis, and pomalidomide or Pomalyst. I'm not saying those are the only 5 drugs in myeloma, but those are really, if you will, the backbone key 5 drugs. So when you hear the expression novel agents, we're generally speaking of those 5. And we've come to appreciate those novel agents, even by themselves, are definitely superior to melphalanoprednisone, and we can use them without melphalanoprednisone and still get the same outcomes. So we could be potentially saving, if you will, the melphalan for later. We know that when we do add these drugs to melphalan, there can be more what we call short-term toxicity. Melphalan is a bit tougher on your bone marrow. It can drop your blood counts. Thirdly, as we're starting to see survival extended in myeloma, and if there's one thing I want to bring to the myeloma community, it's this. We can't have short-term vision anymore. When I see a patient in my clinic, we talk about the long-term strategy, and I fully appreciate that I don't want to minimize their treatment in the short term just to sort of keep chipping away at the disease for years. But on the other hand, I want to make sure that I have a long-term plan for them. This is not a sprint anymore. This is like a marathon. And so sometimes I say to patients this way, it's not a game, but I want to play the best card for you, but I want to play the card that lets me play my other cards later. And so thinking sequentially, if I have a sequential approach, I'm probably not going to put melphalan up front if it's going to cause some issues in the short term, and indeed my final comment here, that maybe even in the long term. We know that all myeloma patients are at risk of getting a second cancer, independent of their therapy. That risk is probably in the range of 4 to 5%. When we add certain strategies, we might increase that more to 7 to 8%. Still a low number, but a significant one. And so we're suggesting that melphalan comes a little bit later. But what are the trends now in treating older patients? Well, first of all, that we're using novel agents. As I mentioned, we're using less melphalan. But the other perhaps important point here, it's not just that we're moving away from melphalan initially and we're using these novel agents. We're treating people for a longer period of time. When we used melphalan, we historically used it for 12, maybe 18 months. Because if you get more than 18 months straight of melphalan, it's pretty tough in your bone marrow, and your good blood counts are going to be affected, and it can cause other trouble. But now that we're using drugs that don't have that same kind of potential to damage the bone marrow, or at least less of that potential, we can use them for longer. And some patients do very well when we just keep our hands on top of the pot and keep the lid on top by giving them continuous long-term therapy. Sometimes the word maintenance therapy is used, or long-term or continuous therapy. And as a result, thankfully, we're seeing increased survival. So when you are initially treated, what's the point? Well, you want to get a response, obviously. You want to see the disease go down. Sometimes we really want to see it happen rapidly. If there's a lot of evidence of CRAB and the kidneys are affected. I just brand new diagnosis myeloma patient this week, a 50-year-old woman. She came into the emergency room because she'd been sick. She was in kidney failure, needed dialysis. Her light chains were extremely high. This is someone where we want to get their numbers down pronto, right? We want to move quickly. Sometimes it's maybe not as urgent to get it down quickly and we can take our time. But very often we want to get it down. And it's not just about getting the numbers down. I always talk about the 2 Ds. It's not just the depth of one's response, it's the duration of one's response. You know, we don't want to get too excited about a number dropping and then shooting right back up again. We want to be able to keep it down. And of course, we're there to improve what we call performance status. I like to say all the time, I don't treat myeloma, I treat people, right? And so I had a patient yesterday in clinic say to me, well, you know, there's this happening in my life and that happening in my life, and I guess we'll just have to wait and see. I said, look, you know, I'm not here to just see your M spike go down. I'm here to make sure you can get to your daughter's wedding, right? So let's take every approach that we can to do that. So that's an important point I would suggest that you take home today, you know, in sharing with your discussions with your family and your physician, that it's not just about, woohoo, my M spike went down by 0.5. No, it's, I have now the opportunity to do what I want to do and to engage my life more, because it's not about a number, it's about a person. Now, sometimes as we've mentioned before, it does depend on the genetics. You know, you can have 2 myeloma patients sitting next to each other. You know, I'm not sure if this happens at the Patient Family Seminar, like, hey there, come here often, you know, what was your % plasma cells, huh? You know? What did your cytogenetics show, right? Been fishing here for long? So, but you can have two patients that, in a sense, almost look identical. They may have the exact same number of plasma cells, the same level of M spike or light chains, but their disease can be very different based on, as Brian shared, the genetics of those plasma cells. I explained to my patients, plasma cells that have gone cancerous are like bad cops. And sometimes there are cops that are just a little bit bad, and then there's some that are very bad. And that's not I'm not trying to insult by any means our police force. We appreciate what they do for us. I'm just using it as an analogy. And so some people can be very sick with the same number of plasma cells as someone else. And that might influence what treatment we give, because we've learned that some cytogenetic features respond better to certain drugs and need more aggressive therapy. Whereas, as Brian mentioned, sometimes when people have, for example, hyperdiploidy or extra copies of certain chromosomes, we know those patients live longer. And maybe we don't have to be as aggressive and give them all the therapies at once. We might be able to approach it more mildly. So most would agree that at least a proteasome inhibitor, so bortezomib or carfilzomib, or an immune modulatory drug, thalidomide or lenalidomide, are needed, and sometimes we might put both of those classes of drugs together in certain situations. And then in addition, most people will add a steroid to that to boost the response. And sometimes they might add something called cyclophosphamide that many of you are familiar with. So I'd rather give you this kind of approach than just listing all the different trials. So that means some people will get lenalidomide and dexamethasone, or lenalidomide, cyclophosphamide, dexamethasone. Some will get bortezomib, dexamethasone. Some will get a regimen that we often use at Mayo known as Cy-Bor-D. Sounds like an alien, but cyclophosphamide, bortezomib, and dexamethasone. There's certain contexts where thalidomide is still added, or sometimes we put the two biggies together. We give them bortezomib and lenalidomide together in certain contexts with dex. Other new ones that are either emerging or that are still lingering is the carfilzomib-based strategies. So the NCCN has listed the possibility of using carfilzomib frontline, so sometimes it's combined with lenalidomide, and then there's still some context when we're using thalidomide. Well, what's the advantage of combining drugs together? Why don't I just get one drug? Well, we know that you get a better response, and we know that that response, at least in transplant patients, and we can correlate that to those not going to transplant, can improve things in the long term. I'm not going to bore you with some of the work that we do in our lab, but we're come to appreciate that in a lot of patients, it's actually really not one myeloma that you have. You actually probably have different, what we call clones, or different malignancies wrapped in one. And it's kind of like thinking of your lawn has several different weeds. And if it has several different weeds, you might need different kinds of weed killer to get rid of those weeds. And so it's important for us to be able to synergize the effect of drugs. So what makes me choose one strategy than another? And this is maybe if you've been napping, wake up for this one slide and go back to sleep. This is what's important, that risk status that we talked about, the FISH status or the cytogenetics. But also if you really need something rapid. So we've learned that certain strategies like bortezomib tend to work very quickly early on. So in our patient who came in this week with the kidney failure in the emergency department, we treated her with bortezomib within 24 hours, and she had a very rapid response. Kidney function might affect because certain drugs are cleared or not cleared by the kidneys. Other diseases like having heart disease or diabetes and so on might influence. Someone mentioned about dexamethasone earlier. I might modify my dose of dexamethasone when I know someone has these things. The patient preference. You are important in this equation, and I know I can sound like I'm getting brownie points by the doctor saying that, but I like to get my patient's opinion. I'm not the kind of doctor that says you'll take it and you'll like it, right? I mean, that doesn't work. Here, dear, take this pill. Trust me, I'm your doctor. We don't really do that anymore. It's got to be a communication with you. Sometimes the own institution has certain protocols that might be of benefit. Cost is important, and I know that sometimes we don't like to talk about cost of drugs. And I really applaud the efforts of the IMF to address this issue because it is important. You look at this and you say, wow, we've got these new regimens that are getting people into really deep responses. We call VGPR, or a 90% reduction of the tumor. Well, the reality is that can vary from $100,000 to $250,000 a year. That's a lot of money. And so we want to make sure that we're using it rationally and appropriately for every patient. All right, a few more slides and then I'm going to close so we can go to some questions. One of the key studies I would suggest that has perhaps influenced us the most in treating patients who aren't going to transplant is what's called the FIRST trial. I don't want to get into too much detail, but the bottom line here is it compared 3 strategies of giving just lenalidomide and dexamethasone as long as the patient was in remission until they relapsed, giving it for only 18 months, or giving the old school melphalan, prednisone, and thalidomide strategy. And the bottom line here is that the strategy of giving lenalidomide and dexamethasone continuously did significantly better than the other 2 arms, both in what we call progression-free survival and indeed ultimately in overall survival. And it taught us something. It taught us that when you take people off treatment, that's when their disease started to wake up. And so this is one of the moves now to not just treat people for a year or 18 months, but to treat people continuously. And lastly, we've also learned that as people get older and as our bodies become a little bit more frail, we have to modify the doses of these drugs. It's not like everybody's got to get 40 milligrams of dexamethasone and full dose lenalidomide and full dose bortezomib. This is a chart that I've given you for your reference. No one's going to memorize it, but a suggestion by a group, including Antonio Palumbo, who was mentioned today, that as we get older, we can dose modify each of these drugs as we care for patients. And part of that, for example, is using bortezomib subcutaneously to reduce the risk of neuropathy, which is something now we routinely do because it still is as effective as it was given IV, but it is much less toxic. For time's sake, I'll skip the carfilzomib. So take-home pearls, we don't like to mix lenalidomide with melphalan because of some of the challenges. We don't use melphalan in most patients up front. We don't want to interfere with people's so-called quality of life, you know, that it's important to do that. Avoid high doses of steroids. And don't ask patients to drive too much, right, as I like to say. We like to try and find convenient regimens that provide that. We've tried to summarize much of what I've said today in what we call the MSMART guidelines. I'm not trying to be a commercial for them, but if you'd like to go to msmart.org, you could find the details. And what we've done is we've just tried to give guidance to the community physicians as to how to care for patients. And there's a lot of detail here, but the short version is that when people have more standard risk or more standard myeloma, we tend to use less drugs together. When people have more aggressive myeloma, like the P53 deletion or the deletion 17P that Dr. Dury mentioned earlier, we tend to be a bit more aggressive in the way we treat them. I think of it as slow-growing myeloma. The tortoise doesn't need quite as much action or drugs to keep it still, or fast-growing myeloma that clearly needs more work. And thankfully, that's not the end of the story, that there's a lot more to come. And you're going to be hearing about this later today, so I'm not going to go through it in any detail. But we have a whole series of new drugs coming, of which we really think one in particular, the anti-CD38 molecules, what's called daratumumab, and another drug called SARS 650984, which just got a new name, isatuximab, will be drugs that, I know, who comes up with these names? I think one of my best friends has a daughter named Isa, so I think of Isa wearing a tuxedo. Isatuximab, right? Everybody? Isatuximab, there you're in. And so there are some studies already that I'll leave that you have in your handout referring to adding some of these agents like daratumumab to the upfront setting, because the beauty of these agents is that they don't cause the kind of toxicities that many of our other drugs do in myeloma, like lowering blood counts or causing neuropathy or others. So I'm going to leave you with that and just give you some hope that we have a lot of drugs in our portfolio now, but many more that are coming, and we're already seeing that it's affecting the average survival of patients. This is our Mayo Clinic database. We're about to include the 2010 to 2015 number, and we're going to be drawing a curve that looks a little bit like this, which means that that what we call median survival, or the average survival, is probably going to be landing around the 14-year mark. So I will stop there, and thank you very much for your attention.
Thank you so much, Dr. McHale, for this excellent presentation, and with the sprinkling of jokes, very good. You got very good applause. If I could ask Dr. Bessio to come up and Is Jean-Luc here?
Yes, he is.
All right. Jean-Luc, if you'd like to come up, also you can help us with the panel here. So please welcome, this is Professor Jean-Luc Harassot from France. So he's traveled all the way here from France.
Yes, just yesterday.
Yeah. And you'll be hearing from him after the break, but obviously a major expert in the area of transplant, so it's really a pleasure to welcome Jean-Luc. So questions?
Questions? Are you
Okay.
kidding me? Really?
Oh, it's all so clear now, they don't have any questions.
Yeah.
Okay, I got one over here. I paid him $5 earlier. I said, if nobody raises their hand, go for it.
Thank you very much, Doctor. I really appreciate your speech and your humor. I know that I'm outside the not transplant eligible patient base, but I had a question that perhaps you could give a little guide on. If you're trying to make the decision as a patient that you're on the borderline of either just doing the drug routine cocktail or going forward with the transplant, and you have the added factor of amyloidosis, would that likely, in your opinion, tip the balance to go forward with the more aggressive high-dose chemo transplant as opposed to just the drug routine and watch?
Tremendous question, and I'll answer it simply, I guess, is that, so for those who aren't familiar, amyloidosis is a disease that can be associated with myeloma, although generally speaking, we try and think of it as a unique disease unto itself. When I teach the residents, I draw two overlapping circles, and I say, this is myeloma, this is amyloid, they're two separate diseases, but there is an area of overlap. There are people who would, if you will, formally meet the criteria for both. One of the key things we've learned with amyloidosis, to some degree I said already for myeloma, you want to get that disease down right away, right? And that patient who came into the emergency department this week, we needed to get her light chains down fast because they were damaging her kidney. In a similar capacity, amyloidosis is a disease where the light chains that are made by the plasma cells in the bone marrow undergo a conformational change and deposit into tissues. And it's very critical to get that light chain level down very rapidly. So in answer to your question, if the drug therapy is not getting that level down very quickly and keeping it down, so the concept of minimal residual disease or getting rid of every last vestige of amyloid is very important. It's important in myeloma, but perhaps even more important in amyloid. Then that might tip me to go towards the transplant. We have pretty good evidence for transplant. That being said, we have some people who get treated with a bortezomib-based regimen and their light chains disappear in amyloid. And because sometimes patients with amyloid can have heart and kidney involvement that can make a transplant more difficult, we sometimes don't go to transplant right away. So it's kind of a paradoxical answer that I'm giving you, but yes, if someone doesn't have that big drop and they're healthy enough to go for transplant, we'll generally push it. On the other hand, if they get a good drop and maybe they're not as good a candidate as it were for transplant, we may delay it.
Maybe I just ask Jean-Luc to comment. So you would routinely consider high-dose melphalan in the presence of amyloid? If you could do it.
I fully agree with that Joe said. I think that amyloidosis is a good indication of a high-dose therapy plus autologous transplantation, but there are some risks, especially in patients who have several organ involvement and mostly heart involvement. So the results of autologous transplantation are good in amyloidosis, but the toxicity is higher than in multiple myeloma. So the decision should be taken carefully. And I agree that if the non-intensive treatment is very effective, then you probably don't know autologous transplantation. And if the result is not enough, you should consider autologous transplantation, but with a good evaluation of all organ involvement, especially heart involvement.
All right.
Okay, right back here, doctors.
The
question is about cytogenetics. If somebody had a hyperdiploid trisomy with no evidence of 17p deletion or 414 translocation, how often they transform into high-risk cytogenetics, and what is the cause for that?
Okay, so
sorry.
So if a patient has a trisomies, hyperdiploid, and at the beginning has no 414 or 17p, how frequently might they acquire some of those high risk later?
So it's a great question. It's hard to give you an exact number. As I mentioned, if we look at almost any database, including ours at Mayo, very often, but not uniformly, the people who live the longest are people who have had these trisomies or these hyperdiploidy or extra copies of chromosomes. Again, Brian mentioned we don't really know why, but it's just a phenomenon. It's also interesting that there's a small group of those patients who actually never get into complete remission and still live a very, very long time. It's like they've been returned to what we call an MGUS state. That being said, when I showed you that slide that we differentiate people based on their standard, intermediate, and high-risk status, just because someone starts in standard risk, it doesn't mean they'll always be there, which is one of the reasons why we repeat the FISH testing every time someone relapses, because unfortunately, this disease can evolve and people can acquire these things later. If I have a patient who's pure hyperdiploidy, the likelihood that with their relapses they're going to become high risk is low, but I can't quantify it. I'd probably say somewhere between 1 in 4 and 1 in 3 of those individuals will later become high risk. But the majority will still stay standard risk throughout their myeloma life. But it's a challenge to give exact numbers, because we're now just evolving in our understanding of it and being able to capture those. So I think the take-home message is, trisomies are associated with longer-term survival, but there is always the risk of unfortunately changing from a low risk to a high risk category.
Okay. So we have a question over there,
Question
number 3.
over here, please.
Okay. Go for it.
Yes, specific to the take-home pearls slide, there were 2 items on there that maybe the panel can elaborate on a little bit. The first one was don't mix lenalidomide with alkylators. Is that true for 4 treatment combinations, and where does that general theory come from? And number 4 was avoid high doses of steroids. What is considered a high dose of steroids? Or what are you looking for to say that's too much for that patient?
Great question. So the first take-home pearl, I apologize I didn't spend as much time on it because I with time's sake, I skipped over the slide that had shown there was a study that Dr. Palumbo led where they had melphalan, prednisone, and Revlimid together, the MPR study. And it was a 3-arm study where there was MP by itself, there was MPR, and then there was MPR followed by continuous R. And basically what we learned was there was no difference between MP and MPR, which was shocking, because when we did MPT versus MP, MPT was better. When we did MPV with Velcade, it was better than MP. So why wouldn't MPR be better than MP? And it was because lenalidomide and melphalan have very much overlapping, we call toxicities. They both really drop blood counts. So you're you're unfortunately almost doubling up on doses, and you end up having to dose reduce so much so that you're giving ineffective doses of it. So the preference, very rarely now do we put melphalan and Revlimid together, is the bottom line. We just tend to give Revlimid continuously. So I was using it in that context. So not very often will you see those 2 drugs used together. The second take-home message, look, everyone in the world thinks that every myeloma doctor doesn't understand what high-dose dexamethasone means, right? Because we say 40 milligrams a week is low-dose dex, and they think you're cracked, right? That's 200 milligrams of prednisone, that's high dose. But compared to the high doses of giving 40 milligrams daily, 4 days in a row, 4 days on, 4 days off, some of you I'm sure experienced that, and now we've reduced it to the so-called low-dose 40. My general practice is, in someone over the age of 65, it's not like we cut it off or be ageist. Generally speaking, I won't give them more than 20 milligrams a week. And remember, the purpose of the DEX is to boost the effect of something else. I rarely keep someone indefinitely on that amount. The most critical time for someone to be on dexamethasone is those first 2, 3, or maybe 4 months of treatment, and then we'll often drop it to 12 or to 8 or to 4 or even discontinue it with time. Because no one likes dex in the long term, nor the patient nor their spouse, right? Am I right or am I right? All of those who agree, sit down. See? Almost unanimous. So I think we want to be careful with how we define it. And it's really not defined by a number, it's defined on how someone reacts to it. There's some people, even at 20 milligrams, it's too much for them, and we have to dose reduce, and sometimes we can go to every other day prednisone. Am I on dex?
Are you on dex?
I'm high on Susie today, apparently.
Okay.
Oh, Suze. I do love you.
Love you, baby. Dr. McKelly, your number 2 take-home point, don't use melphalan in most. I think you explained that, well, first we're talking about what used to be the standard of care for non-transplant patients, and so that's relatively low-dose melphalan for a fairly long period of time. And you pointed out that can cause marrow damage that may make later treatment more difficult, if I understood it right. So how does that?
You should give the talk.
No,
It was brilliant.
Yeah,
Well
well,
said.
my question then is of course,
you are clear.
for those who are getting a transplant, the main treatment is high-dose melphalan, and so does that cause the same sort of problem with precluding later treatments that is damage to the marrow that might be long-lasting, and is that an argument against the transplant?
It's an excellent question, and I will let Dr. Harisu answer it. I'll start with the answer is that there is a bit of a difference between giving it continuously over a long period of time. That seems to sort of beat down the marrow more than that one single punch. But yes, there is some evidence that with time, as we know in the old days, it was harder to collect stem cells from patients after they had previously had a transplant, which is why we try and collect it up front. Now we have newer drugs and different ways to try and collect things a little bit more. But yes, there is some modulated risk of that, but that has to be balanced with the benefit of putting the disease down, right? So there's always some collateral damage, right? As I kill the weeds, there's some good grass that might never really grow back well. But it's all a question of balance. I don't know, Jean-Luc, if you have more to add to that.
So Jean-Luc, I think that you're going to talk about it in your talk, but you can maybe comment briefly now.
Very shortly, I think that you shouldn't compare long-term low-dose melphalan for 1 year, 2 years, 3 years, which I agree is toxic for the marrow and may induce higher risk of second malignancies, including myelodysplastic changes and even acute leukemia. So we all agree that long-term low-dose melphalan should be avoided. I have to say that in Europe, we still use limited duration of low-dose melphalan for elderly patients, and you quoted the MP-TAL or the MP-Velcade, which used melphalan for 18 months, so, but not more, certainly not more. And the second way of using melphalan is high-dose melphalan. Consider that it is a single shot, only one injection of melphalan. And there the risk of chronic marrow toxicity is very low. And I think that we still continue to believe that, and I will try to explain that in a moment, that high doses of melphalan are better than low-dose continuous melphalan, more active, less toxic.
Yeah, so we'll wait for that. But a key point is that after you give the high-dose melphalan, you give the stem cells back afterwards, so they're not getting exposed to the melphalan.
They are protected.
Right?
They are protected.
Anyway, it's a practical point.
One question we have, if we want to perform a second autologous transplantation when the patient relapses 3 or 4 years after the first, so then you're right, it's difficult to collect stem cells to perform a second autologous transplantation, which in a way shows that there is some form of neurotoxicity.
Right. Okay. Other questions? Okay, maybe one or two more, and then we take a break, okay?
I have one here. Go ahead.
All right, go ahead.
Hello, thank you all. I appreciate that the assumption here is that short of age being a factor or other criterion such as health, that the transplant is the preferred method, particularly now. The question that my doctor has posed to me is that I'm relatively healthy, and the feeling is that there are so many new meds coming on board, and it will take another 10 years for them to really be tested out against, for example, transplant. But unless there was a good reason for transplant, he would say, why not go with what seems to be working? And I imagine your answer will be, but we don't know yet what the long-term is. Transplant is still showing up better. But can you give me an idea of what you imagine might be coming up? I mean, are we looking at perhaps less emphasis on transplant over the next 5 to 10 years? You know, if you could maybe address that difficult question from
You know, it's a great question, and it's one that we face every day. And there are people, even within our myeloma community, there are transplant dissenters, right? There are those who say, thou shalt not transplant, right? Because of the progress. And, you know, that's why I think I tried to mention that I do suspect that in the upper age end of where we're transplanting people now, in that sort of 65 to 75 time, where transplants are a little bit more difficult on the system, where, let's be blunt and honest, people aren't expecting to live to 110. Well, I guess if they follow
Well, of course,
Brian's
for me,
diet,
but-
you are. You know, where you know, if I say to a 75-year-old patient, you know, if your expected survival from your myeloma is 10 to 15 years, that's pretty good. That's a lot different than the 25-year-old I had in clinic this week, right? So we have to modulate that. So that's why I wonder in that group we might be using transplant a little bit less. But I think where we're going to go is to view transplant as another option. That just like I said, it's an individualized plan for everybody. There's some people in whom transplant might be ideal. I had a patient recently, they had a bortezomib-based regimen, it barely moved their disease. They had then a lenalidomide-based regimen, barely moved their disease. We transplanted him, he went into complete remission. That person was clearly very sensitive to melphalan, and so that was the right thing to do for him. So we'd look at it as not always the big first card to play, but one of the cards to play. But I also think we have to be cautious that I'm not much of a boxer, but you know, you're the champ until someone knocks you out. And in many respects, in eligible patients, transplant is still the champ. I'm trying to boost my friend's talk here in a few minutes, right? You know, and it's not we get anything personally beneficial, but you know, it's a little bit of a difference giving one single shot of a drug as opposed to being on something else for 4 years that you take every day. So it's hard to match that pound for pound, right? So that's why I don't want to just dispense with transplants, but there may be some people that will do it less and will be using it as one modality, not necessarily as the central modality in the future. And in your situation, what I'm telling most of my patients is, until we really know if someone's eligible, I would at least collect their stem cells and freeze them, because that keeps the options open later.
So before we leave this, Bob, do you want to comment on what's the perspective here in the Los Angeles area, where there are some, there's a little diversity of thought?
There is.
Slight diversity.
There is a diversity. So there are those in the area that really feel like the risks and kind of the morbidity, the side effects from the transplant really isn't worth it. But I think it's hard, even with all these studies that we've done and ways of trying to identify good risk, bad risk patients with multiple myeloma, ultimately we're trying to predict the future for people, and we can't fully do that. And for people that I know are even in the room, when they could look back, for them, the transplant was clearly their best treatment and allowed them to be in remission, off treatment, or on very easily tolerated treatment for a long period of time. And even the center, kind of in the area, has some of his longest term patients that I transplanted with him, let's say, and have done well for many, many, many years. So I think it's a for some people, it can be the most effective treatment, and sometimes you find out a little late that maybe it should have been done, and there's always, you can make the argument, you know, for those people that, you know, should have been, the transplant could have been done, and I think the other thing for patients to understand is that people tolerate the transplant better than they did 10 years ago. It's not as terrible. It's easy for me to say, but it's not as terrible as it used to be, and people go home. I don't really get nervous about people dying from the treatment. It's just kind of how much diarrhea they'll have and how many weeks it'll take for them to get back to normal. So you just don't want to not use a weapon that for some people could have been their best weapon.
Okay, so good introduction for the topic coming up. I think that maybe we should leave it at that. I think that we are up to the coffee break. So thanks to Joe, thanks to the panel. See you back in a few minutes.
Good seeing you, Paul, as always. Thanks for coming up.
Very useful, very confusing sometimes, but you get there.
Shh, quiet, quiet. Quiet.
If, by the way, if someone could find the other changer that's got the pointer, we do need it, okay? The pointer that works is going to be helpful versus the one that doesn't, which we have here. Thanks a lot. There we go. Yeah, that one's working. Okay, so just take your seats there. All right, so I'm very, very pleased to welcome Jean-Luc Harassot, who comes from France. He lives about a couple of miles to the west of Paris in a place called Nantes. And he has worked for many years at the University of Nantes, where he developed a very, very famous transplant program for myeloma. And he's also the founding president of something that's called the IFM, as opposed to the IMF. And so over the last 25 years, we have had the IMF and the IFM, which is the French myeloma group, which is based in Nantes. And so this has been really one of the pioneering groups in the treatment of myeloma over all these years, especially focused on transplant. But in addition to that, Jean-Luc is also a politician, and in fact was a local politician for a number of years, right? And more recently was actually asked by Sarkozy, the president of France, to work in Paris as basically the advisor for like the French FDA for the review and the access for drugs for the hematologic malignancies, including cancer. And so he's been very much involved in the review of the new drugs and the access to those drugs for patients with myeloma. So he really has a broad expertise in myeloma, and so it obviously gives me great pleasure to welcome Professor Jean-Luc Harassot.
Thank you, Brian, for your kind words and for your welcome. No need to say that's a great pleasure for me to be here. And it's the occasion to remember when we started some years ago the Patient and Family Seminars in Paris, France, with Susie and Brian. So, well, my task today is to try and explain how we did improve the concept of autologous stem cell transplantation. And since the question is what are the best therapy for patients opting for transplant, I would like to first start by addressing the question of why should we opt for transplants. And I would start with this first busy slide, which is back to the 80s, when the concept of autologous stem cell transplantation was introduced. And at that time, there were no other treatments than alkylating agent, let's say melphalan, and corticosteroids. No other drug was effective. So really, the use of hydrotherapy was an innovation. And the idea was that higher doses of chemotherapy, and let's say melphalan, would be more effective, would induce deeper responses, and of course, longer responses. And it turned out that it was true, and the initial period was somehow difficult because we had no support by marrow. And the idea of supporting hydrotherapy by autologous transplantation was developed both in Europe and in the United States, and I would say that Bart Barlogi here in the United States was one of the pioneers of the concept of autologous transplantation. So the idea is more is better. And I repeat that compared to low-dose melphalan, it's a single shot of high-dose IV melphalan. Autologous transplantation means hydrotherapy. It's not a transplant. It's just a support by the patient's cells, which are collected prior to hydrotherapy, stored in nitrogen liquid, and re-infused after the toxic hydrotherapy. We currently use stem cell collected in the peripheral blood, not because we believe that the contamination by malignant plasma cell is lower. It may be, but it's not the true reason. The true reason is that the number of hematopoietic stem cells is much higher. So the duration of aplasia after the hydrotherapy is much shorter, and the safety of the procedure is much better. So in the 90s, there were a number of randomized trials comparing conventional chemotherapy and high-dose chemotherapy. And the paradox is that the only negative study comes from the United States and was published by the pioneer, by Bart Barlogi. But in this particular study, the last one here, there is, how did it work? I don't. Oh yeah, okay, good. So this one showed no benefit in terms of response rate, progression-free survival, and overall survival. All the other published studies shows at least some form of benefit, and 3 studies show a benefit for overall survival. The first published study, which was our own study, the IFM, the British and an Italian one. So based on the results of our study, the IFM study, which was published as early as 1996, in many countries, autologous stem cell transplantation, I should say hydrotherapy plus autologous stem cell transplantation, had become the standard of care for patients fit enough to tolerate this treatment. And I'd like to repeat what Bob Vecchio said. Initially, it was a little bit toxic with long hospitalization, sometimes in sterile unit. Now it's very well controlled, and I can say that it is a very safe procedure. Of course, it's usually performed at the hospital, and it's more cumbersome than having pills at home, but it's becoming very safe for the majority of patients. So from this initial period, first, as I said, autologous transplantation became the standard of care because it was admitted that the best way to prescribe alkylating agent, again, this was the only treatment. So the best way to prescribe the alkylating agent was to give high doses of alkylating agent. Second, hydrotherapy was superior to conventional chemotherapy in terms of response rate almost always, progression-free survival almost always, overall survival not always. And why the benefit in terms of progression-free survival and response rate didn't translate always in a benefit in overall survival? It was mostly because patients could receive autologous transplantation at time of relapse when they didn't receive autologous transplantation up front. So that was a good treatment, but there was a deception. When I started autologous transplantation, I thought that it would cure patients. And actually, it didn't cure patients. It prolonged response, but ultimately, all patients did relapse. So we said at that time, already at that time, that we should do more than autologous transplantation, and this is now possible with the novel agent. But the most important information coming from this historical period is that there is a close relationship between the quality of response and the final outcome. And maybe you don't see the blue curve here. It's patient achieving at least what we call very good partial remission, 90% reduction of the monoclonal component, or complete response. And patients with VGPR or CR have longer progression-free survival and overall survival than patients achieving only PR. So from this initial period, it turned out that the objective of the treatment should be now to achieve CR. And this was confirmed by many teams. For instance, here, a study from Spain showing that patients achieving CR after transplant have a better outcome than patients achieving only VGPR or PR. So the next step was, of course, to try and achieve a high complete response rate, which became the new objective of myeloma treatment. And by the way, this importance of CR achievement led us to change the classification of response to treatment. And Brian remembers the historical period where CR was so rare, and even they didn't mean CR. Patients in CR were not in CR. So he had the initiative of changing the classification of response to treatment, introducing the concept of CR and of VGPR. So now we have the novel agent, and the idea was to improve the results of hydrotherapy with novel agent. And there are different ways for doing that. First is to improve the induction treatment prior to autologous transplantation. Again, the objective of induction treatment are, of course, to decrease the tumor burden before autologous transplantation in order to increase the final response rate. Second, to decrease marrow infiltration, it's better to infuse a marrow without malignant cell than with malignant cell. And third, to ensure optimal stem cell collection. That means to avoid melphalan, which is toxic for the marrow. The modalities of induction treatment are the following: short-term treatment, maximum 6 courses, usually 3 to 4 courses, on an outpatient settings and with drugs having a limited toxicity in order not to postpone the autologous transplant. Historically, we avoided melphalan, and the induction treatment was dexamethasone-based, but not very good for, as concerned the response rate. Now, this slide summarizing all the randomized trials which compare different induction therapy. And you see here the historical induction treatment, which was the VAD regimen with vincristine chemotherapy, adriamycin chemotherapy, and dexamethasone. And you see that the response rate, it's here, the VGPR, very good partial remission, is very low. And all the new combination were significantly superior to the historical induction treatment. And there were 2 drugs therapy with thalidomide or Velcade dexamethasone, or 3 drugs with thalidomide or Velcade. And the results of all these studies show that not only the post-induction treatment is improved, but also in red, the post-autologous transplantation CR rate is increased. And historically, we had less than 50% CR plus VGPR. Now, we have almost 80% CR plus VGPR with the new combination. So the conclusion of these studies is that compared to the historical induction treatment, all novel agent-based induction therapy increase the CR plus VGPR, not only by itself, but also after autologous transplantation. Second, that bortezomib-based combination are superior. And you see here that Velcade dex looks superior to thalidomide dex. And this is due to the fact that bortezomib-containing regimen are superior for poor-risk disease, patients with a higher international staging system or patients with poor-risk cytogenetics. So bortezomib is better for those patients. We now know that a three-drug combination, let's say triplet, is better than a two-drug combination. There are three randomized trials. We show that VTD, Velcade, dexamethasone, thalidomide, is superior to TD or superior to VD. So the current induction treatment is a three-drug regimen, and it is recommended both in the United States and in Europe. I can say that the standard of care is VTD, but other triple combinations are as active, and we know the PAD with adriamycin bortezomib, the VCD with, or the CyBORD with cyclophosphamide plus Velcade and dexamethasone, or the more expensive, maybe more active, I don't know, but the more expensive Revlimid, Velcade, dexamethasone, which is commonly used in the United States. So is it possible to further improve the results of induction therapy? The objective would be probably to further increase the efficacy, but also to decrease the possible toxicity. And what are the possibilities? The first is to add a fourth agent to be more active. This has been done, but we currently can say that 4 drugs is not superior to 3. There is an experience in Europe published by Heinz Ludwig, and an experience here in the United States published by Sarji Kumar showing that 4 is not better than 3. So, second possibility, to replace bortezomib by another proteasome inhibitor like carfilzomib. The objective would not be to be superior, but to be less toxic and to induce less neurotoxicity. And maybe for the future, instead of adding a fourth agent like chemotherapy, adding an antibody. And it's a great hope in myeloma treatment to use antibodies, for instance, the anti-CD38 daratumumab or the Sanofi product to further improve the efficacy. Just a word on carfilzomib and new proteasome inhibitors. There is some experience with a 3-drug combination using bortezomib instead of carfilzomib instead of bortezomib, and these are the papers which have been published. The interest would be a lower incidence of peripheral neuropathy. Carfilzomib is almost not neurotoxic. There has been in the past concerns regarding cardiac toxicity, but my point is that currently we don't know which is better because there has not been direct comparison between carfilzomib and bortezomib in the setting of induction treatment. Future might be new proteasome inhibitors, for instance, ixazomib, which is an oral drug. And I would like to finish the induction treatment with 2 questions which are often raised. The first is what to do if response to induction therapy is less than VGPR, if the patient does not respond very well to the treatment. Should we treat another way, change the induction treatment, or should we go directly to autologous transplantation? My position, and there are some arguments in the literature, is that we should go directly to autologous transplantation because it's difficult to find a new combination which is better than the first. So you lose time and you should go directly to a high-dose treatment, which is, as Robert Vescher said, which is a very good treatment of multiple myeloma, maybe the best treatment of multiple myeloma. So the second question is is autologous transplantation still necessary if the patient achieved a complete remission after, let's say, 3 or 4 courses of VTD or RVD? That's a difficult question, and we currently don't have a scientific correct answer. My personal opinion is that, yes, you should go to transplant if it has been decided before. The reason is that we could upgrade the level of response, not only achieve a CR with a negative electrophoresis, negative immunofixation, but achieving an even better level of CR, and I will discuss that in a moment. Second way to improve the results of autologous transplantation with novel agent is the consolidation therapy. The objective is to further increase the response rate, and mostly the complete response rate, but also, as I just said, to upgrade the level of CR and to achieve minimal residual disease as defined by flow cytometry or even molecular biology. It's a better level of response. The modalities might be, well, by the way, autologous transplantation is a sort of consolidation, as Joseph nicely showed in his cartoon, showing that autologous transplantation is a consolidation after induction treatment. So yes, autologous transplantation is a sort of consolidation. But if you want to further improve the CR rate, there are 2 modalities. The first one was tested in the late 90s. It's a double transplantation, and we did work on double transplantation following Bart Barloghy. Again, it's very cumbersome. The patient is at the first transplant, and then you have to come back to the hospital to the second transplant. And to be honest, we have never proven that the second transplant is really superior to single transplant. It's superior in terms of progression-free survival. I'm not sure it's superior in terms of overall survival, except in some patients with very aggressive disease for whom maybe there is a place for second autologous transplantation. But usually, in the United States, as in Europe, consolidation is based on novel agent, 2 to 4 courses, either bortezomib alone. The Swedish group, the Nordic group in Europe did that. Not very convincing, in my opinion. Mostly with a combination of bortezomib plus IMiDs, thalidomide or lenalidomide. And this is, this is the reason why it should be important to have consolidation to further upgrade the level of CR. It's a Spanish study showing that patients achieving immunological complete response have a better outcome than patients achieving only CR with negative immunofixation. So this is a design of a study from Italy using new drugs plus double transplantation. The induction treatment is VTD versus TD, and VTD is better, and the consolidation is the same, VTD versus TD. And it turned out that VTD is superior to TD, as I said, but also that consolidation with VTD further improves the level of CR, the percentage of CR after autologous transplantation. This is the design of a study which, should be finished now next year, which is a very important one, which is trying to address the question, if a patient do receive maintenance, and I will explain what is maintenance, is it necessary to perform consolidation? So one arm is no consolidation, one arm is a double transplant, and the third arm is consolidation with novel agents. So it's very important, and we are waiting for the results of this important study, which compare after transplant to consolidation and no consolidation. And this slide is just to confirm that it's sometimes important to achieve a higher level of complete response rate. It's based on an Italian study with a VTD combination, and some patients not only achieve CR, but also achieve molecular CR, so the minimal residual disease. And those patients achieving molecular response did very well and better than patients achieving only CR. And in my group, we looked at immunophenotypic responses after VRD induction and VRD consolidation. And at the time of the analysis, patients with immunophenotypic remission had not relapsed. Of course, it's a short follow-up, but the hope is that patients achieving immunophenotypic CR will have longer remission than patients achieving only CR, and that is the interest of consolidation therapy. I'd like to finish with maintenance therapy, and the objective is slightly different. It's not really to improve the CR rate, or to upgrade the level of CR, but it is to maintain the response rate, the complete response rate. And the modalities are quite different. These are prolonged treatments with a drug which, of course, should be well tolerated. If you want to give the drug for a long period of time, it has to be well tolerated. And, of course, oral route is preferable. And there had been an experience with the thalidomide, and a big experience, because this slide shows that there were 6 randomized studies comparing thalidomide maintenance, continuous treatment with thalidomide, and no maintenance. And all 6 studies showed an improvement of progression-free survival. But overall survival was not improved in all studies because of the quality of the salvage treatment. Patients who did not receive thalidomide could be better salvaged at the time of relapse because they could use thalidomide initially. Of course, nowadays, this would change because we have more opportunities for the relapse treatment. We have bortezomib, we have lenalidomide, pomalidomide, carfilzomib. So I think that the prolongation of progression-free survival would probably translate into a prolongation of overall survival. The problem with thalidomide is not the efficacy, it's the toxicity. And you probably know that thalidomide induces a high rate of fatigue, but mostly a high rate of peripheral neuropathy. So if you want to use thalidomide, which is still used in poor countries where lenalidomide is simply not available. So if you want to use thalidomide, you should use low-dose thalidomide, like 50, maximum 100 milligrams per day. Bortezomib has been used as a maintenance by the Dutch group, and this slide shows that bortezomib for induction and for maintenance slightly improves the prognosis compared to the classical VAD and to no maintenance. But it's not really convincing, and in my opinion, bortezomib, which is administered IV, is not very convenient for consolidation, long-term consolidation treatment. So I would prefer lenalidomide, and we have a large experience with lenalidomide maintenance, which is used with low dose, 10 milligrams per day, and usually until progression or until severe adverse event. And currently we have 3 large randomized trials which has addressed the question of lenalidomide maintenance versus no lenalidomide, no maintenance in patients who did receive autologous transplantation. And this is the design of our own French study. After autologous transplantation, patients were randomized. They all received a consolidation with 2 months high-dose lenalidomide. They were randomized to receive either long-term low-dose lenalidomide or placebo until progression. And the results have been published in the New England, and I don't want to comment the curve, but it's just to show the dramatic improvement of progression-free survival in the lenalidomide maintenance arm compared to placebo arm. The US intergroup had the same result, and they have even a better result because overall survival was slightly improved, which was not the case for the French study, and which is not the case for the third study, the Italian study. Our problem was the incidence of secondary malignancies, both in the French and in the US study, with myeloid dysplastic changes or acute myeloid leukemia, but also solid tumors. There's been a great concern. It turned out that finally it's not so important and that the incidence of these secondary malignancies is not so high. There has been a paper published by Antonio Palumbo last year emphasizing the fact that the risk is higher when you give lenalidomide and long-term melphalan. So the conclusion we draw in France from this risk is that maybe you shouldn't use long-term lenalidomide, and I will discuss that on this slide. So the question, well, lenalidomide is not yet approved in Europe in this indication. There are the risk of prolonged treatment. There is, of course, the issue of the cost, which is very important in many countries. The long-term lenalidomide is very expensive. But the most important question is it really a survival benefit of prolonged maintenance therapy? There is a benefit for the duration of response, but is there a significant benefit for overall survival? It has been shown only in 1 of 3 published trials because the survival after relapse is better in patients who do not receive maintenance than in patients who do receive maintenance. So in our trial, the survival after relapse was much better in the control arm due to a better salvage treatment. So that's really an important question which addresses the question of the optimal duration. Lenalidomide maintenance is certainly useful, delay the progression, but how long? And there are 3 possibilities: until progression, like in the 3 randomized trial, with the risk I just mentioned, fixed duration, and currently in France we focus on 1 year, or, and that might be, in my opinion, the best way, until the best result, like in other hematologic malignancies. For instance, in CLL or in acute leukemia of childhood, you give the treatment until minimal residual disease has been achieved. So you monitor the patient with immunophenotypic evaluation or molecular biology, which is much more difficult, and you stop the treatment when you achieve phenotypic remission, for instance. That might be another solution. So I'd like to finish by a conclusion. This is a summary of what we have achieved in the last 30 years. The conventional chemotherapy period before the 80s, very few CR, short progression-free survival, and median overall survival of 4 years maximum. Autologous transplantation, more CR, some good level of VGPR, better progression-free survival, and an overall survival of, let's say, 5 years. And now with novel agent, as been shown by the previous speakers, and especially by Joseph in his talk, up to 60% CR, median progression-free survival of 3 to 4 years, and overall survival superior to 70% at 5 years. This is a summary of the biologist experience showing the striking improvement and very encouraging results of his current approach with induction, double transplant, consolidation, and maintenance. And this just one question which is often addressed. Should we give the same treatment for all patients, or should we adapt the treatment to the risk of the disease? For instance, should we offer autologous transplantation to patients with higher risk of disease? Currently, the answer is no. Currently, we think that we should give the same treatment to all patients because the treatment is the best we can do, and it's good for good patients or good disease and high-risk disease. And there is no targeted therapy in multiple myeloma which could target a specific subgroup of patients. We don't have this in multiple myeloma. So my personal feeling is that we should give the same treatment to all patients, either they are willing to have autologous transplantation or not, either they are fit enough to have autologous transplantation or not, but you give the same treatment to all patients. And the last question, which has been addressed and which is frequently addressed, especially in the United States, is should we offer autologous transplantation up front, or should we keep the stored hematopoietic stem cell for treatment of relapse, early or late transplant? And there have been several randomized trials addressing this question of early versus late in the era of novel therapy. And this is a design of an Italian study. Patients receive lenalidomide dex, and they are randomized between the not so good combination, MPR, with Revlimid plus melphalan, which is not so good, versus intensive treatment, and they are randomized between maintenance and no maintenance. And there is a benefit for the intensive R, both in terms of progression-free survival and overall survival. And the final slide is to show you the design of the study we have performed in France and in the United States, including several centers in the United States, Dana-Farber Institute and other groups. And this addresses the question of early versus late, but what is, in my opinion, more important is that it will have a number of important tests in order to try and answer the question I addressed: which patient benefit more from intensive treatment, and should we continue with autologous transplantation when a patient has achieved complete remission after induction treatment? So then we will have all this evaluation which will be performed at each step of the procedure in order to better define the treatment for the near future. And thank you for your attention.
So, thank you so much, Jean-Luc. And so, over the years, I've heard a lot of presentations about the role of high-dose therapy and transplant, and you haven't heard those over 10, 20, 30 years, but what you have just heard is a really wonderful capsule summary of what can be accomplished with this approach. So congratulations for this. So we have time for questions. 10 minutes. Okay, so Bob and Joe, you're still here? Yes, come on up. See if we have any conflicting opinions or converging opinions. So questions about the role of high-dose therapy and transplant.
Should we wait for
Go ahead in a second. Yeah.
Okay, first question over here.
What is your best recommendation to maintain remission? And also, what would be your decision based on having second transplant?
Okay, did you hear that?
I couldn't hear.
The second one was the role of second transplant,
and to maintain a good remission. What to do to maintain a good remission?
So, maintenance and second transplant. Second transplant you touched upon, but maybe you could emphasize again, and then the role of the maintenance.
I discussed double transplant as part of the initial therapy.
Yes.
It was an idea we had 30 years ago, based on the experience in acute leukemia, where more is better. So we started to achieve a high complete response rate with the first intensive treatment, and we did want to consolidate treatment with as a result with a second transplant. And in the United States, biology, and I think that Bob Vescio worked on this as well, did push the idea of double transplant as part of the initial therapy is better than single transplant. But the question is second transplant at time of relapse. And I think that, yes, it's feasible if you have stored stem cells. So the question is to collect enough stem cell initially to perform one transplant for the initial treatment and a second transplant for the treatment of relapse. If not, sometimes it's difficult to collect enough stem cell to perform a second autologous transplantation when a patient has been treated for months or years. But the question is, what is the efficacy of a second transplant if the first has failed? I mean, if you have only less than 1 year response with the first autologous transplantation, then, in my opinion, there is no indication for a second transplant, except if you believe that improvement of what we call the preparative regimen, the hydrotherapy, it might change the result. And there are some preliminary experience with the addition of bortezomib plus high-dose melphalan. But I'm not sure that if the first response to autologous transplantation is short, the result of the second transplantation will be good. So our current experience is to offer a second transplant only if the result of the first has been good, meaning in patients having at least 2 years of response after autologous transplantation. I don't know.
Yeah, this is basically the result of a recent U.S. consensus led by Dr. Sergio Giralt in New York. He kind of reached the same conclusion. 2 years, 18 months, but certainly 2 years as the cutoff. Well, I mean, there may be value with shorter remissions, but certainly the consensus is around 2 years.
So we have
and then as far as the maintenance, he did touch on it and said basically that in France, for sure, you do not like open-ended, and you have in the IFM study 1 year of maintenance, right?
Yeah, we don't use maintenance until progression for the reason I discussed, which is if the patient relapses while receiving lenalidomide maintenance, the treatment of relapse will be, for instance, probably less effective than if the patient has no treatment. So we have no real argument for doing that because all the randomized trials were performed with lenalidomide given until progression. But it's my personal experience. I like to have some weapons in my pockets when the patient relapses. So lenalidomide is a good weapon. Of course, there are new weapons arriving, pomalidomide, the antibodies, the new proteasome inhibitors. But still, currently, I prefer to try and prolong response with a short, let's say, short duration maintenance treatment, let's say 1 year, 18 months. Stop the treatment, wait for relapse, and save lenalidomide for treatment of the relapse.
So I was thinking, Bob, do you want to comment on the ideas in the Los Angeles area about maintenance? What would you like to comment?
Well, I've been kind of a believer that since it's hard to cure multiple myeloma, that if somebody's on a treatment that is tolerated, and that leaves a lot of room for judgment, that I tend to keep people on the treatment. And so I've had people, on lenalidomide and some of the other drugs as maintenance for many, many years. And I think it always, when you stop, there's a balance. You have less side effects, it's less costly, but there's the worry that the disease can come back more aggressive, and you can't always, it's not like a light switch where you can always, you know, turn it back on and everything's back the same. So I think it needs to be very individualized. And certainly whatever maintenance treatment, whatever you want to call it, needs to be something that doesn't make people feel ill. I think that's a key component because, you know, there's
To be honest, there's been a discussion between the US investigators and the French investigators for the study. I showed the design. The French stopped the treatment,
right,
while the US decided to prolong maintenance treatment. So there will be a slight
you probably have better
difference.
coverage.
This was an interesting example of international collaboration, where the collaboration was to have a different protocol.
No, they have, Brian, they have a different healthcare system.
Sorry?
They have a different healthcare system too.
Yes, yes. So I think it's obviously not a black and white issue. I think that's individual, and I think that there's some difficult points in terms of the ability to retreat, which Jean-Luc is emphasizing is very important, the second remission. And then maybe one final thing you could comment on, Jean-Luc, is that as far as the second cancers, there were a lot of second cancers early, within the first 1 or 2 years, but more recently the numbers are not increasing, right?
Correct.
So this is a shorter term issue.
The second cancer did occur during the first 2 years.
Yes. Okay. Other
All right, so
questions?
the gentleman has a quick follow-up question.
More questions.
And we only have,
What if-
have 2 minutes, so.
What if the patient had issues with chromosome 17?
What if the-
Abnormal chromosome?
Chromosome 17?
Oh, deletion.
17.
P53 deletion. So this is where I might differ a little bit with
Okay.
Jean-Luc, right? We got to get some controversy here. We're all
Okay,
like
so-
loving each other up here. It's a bit nauseating.
Yeah. So.
Yeah.
So
although I must say, je parle français aussi, so
Let's
it's
start a
hard for
fight.
me to fight with the French, you know. Although when there was that debate at the maintenance discussion at ASH 2 years ago, that was like WWF myeloma. I have never seen the American and the French investigators respectfully fight as they did. You raise a good point. The reason why I might differ somewhat with what Jean-Luc said towards the end of his talk, you know, do we give everybody the same treatment, which we think is the best treatment, or do we risk stratify? I would suggest that at either extreme of myeloma, in the trisomies and in patients with very aggressive disease like the P53 deletion and possibly even with translocation 414, we do have emerging evidence that we can take a different treatment strategy. I had a patient, trisomy. I transplanted him 5 years ago. He's been on nada for 5 years, and he's just relapsing now. So he had 5 years of nothing. That's great in one respect. We've shown from the work I did when I was in Toronto and then at Mayo that on average, with no maintenance therapy, a P53 deleted patient will unfortunately relapse within 9 months of a transplant. So it's hard for me not to want to give that person something because they're at risk of that early relapse. And right now, although it's not absolutely convincing, there may be increased evidence that in that patient, perhaps lenalidomide isn't the best choice. It is an option, but perhaps bortezomib may be more effective in that high-risk patient, be it P53 or translocation 414. It's not guaranteed. There's no absolute consensus on that. But in those people, I would be more interested in providing them proteasome inhibitors for a longer period of time after transplant.
Okay, so I
just 2 words, Brian.
okay.
Just 2 words. I think we do agree.
All right. Okay.
What I wanted to say is that a good treatment for good patients gives a very good results. So currently we give the good treatment to all patients. The question is only for ultra-risk disease. And that we don't know how to treat this patient, we have to say. We give bortezomib, we give lenalidomide, we give all drugs. But currently we have to find other drugs, maybe the antibody, I don't know, but we have to find other drugs. So that's the reason why I said that there is currently no tailored treatment except maybe double transplants, which might be a little bit better for patients with poor risk disease, but it's very difficult to improve the result of those patients.
So I just point out some medical terminology that you're hearing here. When Joe's talking, he said that we have emerging evidence. So what this means is that we don't really know yet, however, this is what we think.
All right.
Because I think it must be right. Right, Brian?
Right over here, Doctor.
Okay.
Go ahead.
Yes, I have a question. In harvesting stem cells, can a sibling donate? Or is it only your own stem cells?
Jean-Luc did not talk about using stem cells from a sibling, or
No.
he did not talk about that, but certainly one can, but this is, for various reasons, not a popular therapy. Maybe you can comment briefly.
Well, yeah, I just discussed autologous transplants with stem cell coming from the patient himself. The true transplant is when you take the stem cell from a donor, which may be a familial donor or an unrelated donor. The question is that what we call allogenic stem cell transplantation coming from somebody else, is much more difficult than autologous transplantation, with a high risk of morbidity and mortality. But even with this high risk, you are not sure of being better than with the classical treatment, at least in standard risk patients. So currently in France, we offer allogenic stem cell transplantation only after first relapse or in very high risk patients, let's say double translocation 414 plus deletion 17p, or high LDH plus poor risk cytogenetics or plasma cell leukemia, so very high risk leukemia. Then in young patients we can propose allogenic stem cell transplantation.
Thank you.
Yeah. So I would just emphasize that this is a very important comment, because the French team have really been the pioneers in investigating this and had studies to see what is the value of this type of an allo or mini allo transplant. So high risk mostly for now. Okay. Other questions?
Okay. Let's stop. Okay.
There's a stop sign, apparently.
Oh, there's a stop sign. Oh, I was looking for the numbers, but there's another one in the middle which says stop.
That big red one that says stop.
Okay, well, we're stopping now. Thank you so much. All right, so I guess we're on schedule. So this update, which I'm going to give you before lunch here, feeds in very nicely with what you've just heard from Jean-Luc about the relationship between the depth of the response and the ability to have long remissions and to maybe even to start to be able to cure myeloma. And so this is the basis of this Black Swan research initiative. And so the project involves an underlying theme, but it has multiple smaller projects within it. Right now, in fact, it has 5 sub-projects, and so that's why right here in the ocean we have the big swan and then some 5 little swans floating over here. It's spawned a number of sub-projects to investigate various aspects of this approach to the treatment of myeloma, with the intent to try to find a treatment that can cure myeloma. So these are the bullet points. These are the basic elements of what this project is all about. And this came from a meeting that occurred almost 3 years ago now to try to think about what would be the way to come up with a cure for myeloma. And so the first idea from this team was that we have to be able to measure myeloma at a very, very low level to be able to figure out what we're doing. If you can't track the disease at a low level, then you actually cannot develop a better therapy because you can't understand what you're doing. And so if you have a complete remission and it's below the level of detection, then it's no good. You need to be able to measure what's called minimal residual disease, which is called MRD, minimal residual disease, myeloma at a very low level. And this allows you to track it there. And then it needs to be a very precise and a reliable test where you're willing to say that we can make a treatment decision based on that. You need to be secure that you can say we are willing to stop the treatment. As Jean-Luc was saying, after 1 year of maintenance, if it's MRD negative, no minimal residual disease, you need to have some degree of confidence in your test that you could stop treatment. On the flip side, if you have evidence of minimal residual disease, part of this project is to understand why is there residual disease? Why is this disease resistant to the therapy? And have some decision to use some other therapy or enhanced therapy to get rid of the minimal residual disease. So there are two parts to this. Stop if you're confident that there's no disease left. Change the treatment if there is some MRD left. So we've been working on this basically for 2 years now. So where are we and what are the next steps within this project? And so to achieve a cure or to attempt to achieve a cure, the key thing is to start early. And Jean-Luc has emphasized what has been accomplished treating patients who have myeloma, as we have recognized it up to now. Myeloma with CRAB criteria, and he showed you the steady improvement with the introduction of high-dose melphalan and stem cell rescue, the improvement with the novel therapies. So a way to do better than that is to start earlier. And if you start earlier, there are two key aspects of that. Number one, there's less myeloma. The second thing is that it's not such ugly myeloma. There are fewer of those translocations and mutations. There is a lesser likelihood of having that 17p or that 414. Unfortunately, what we do know that even if you go all the way back to MGUS, that about half of the patients with MGUS do have some chromosome changes, particularly with chromosome 13, for example. So we know that going early is better, although right now at least it doesn't take us back to where all the patients might have normal chromosomes. But certainly more of them will have normal chromosomes the earlier that you go, and they'll certainly have less disease. Then you need to be able to figure out what you're doing, and then you need to have clinical trials to see if changing your pattern of treatment is going to improve the outcome. So we were very pleased when Vincent Rajkumar, as part of the Black Swan program and as part of the IMWG, put forward this new diagnostic criteria paper, which was published in November last year. And this is the basis for the SLIM CRAB criteria, where we can now classify myeloma at an earlier stage. And it also allows us to separate out patients with smoldering myeloma that are even in the earlier category. And so focusing on these clearer criteria allows us to assess the type of patient that we're offering treatment to with a chance to have a better outcome. And so we've already talked about this. the crab criteria and the slim crab myeloma defining events. This has been a key step forward in our ability to treat myeloma aggressively early with an intent to do a better job. And I'll just skip over that. So the important thing about classifying complete remission is that up to now, it hasn't been as good as we need it to be. And so there are 3 different ways in which we can look at a complete remission. So the first one is to look at the amount of myeloma in the bone marrow. So the traditional way to have a complete remission right now is to have less than 5% plasma cells in the bone marrow and identify them as being monoclonal or myeloma or not. But this is actually a very, very difficult test because just looking under the microscope, it's very, very hard to see is there an occasional plasma cell there or not. And so looking at the bone marrow, we need to go beyond what we call immunochemistry here to use a molecular technique, PCR, which we've used for a number of years, or what is called next generation. Now, this is kind of the modern lingo, next generation. It means right now is what it means, actually. To use either sequencing or a flow method to assess, is there any myeloma left in the bone marrow? So sequencing is that you take the bone marrow and study it at the molecular level. Flow means that you take the bone marrow and you run it through a flow machine, which is able to detect the myeloma cells and to count them and see how many that there might be. The other way to assess if there's residual disease and how good the remission is to look at the production of things that are coming from the myeloma. As we've talked about during the morning, the myeloma cells, they produce the spike. It's possible to measure the spike using much, much more sophisticated and sensitive methods. That's not routinely possible right now, but it could be accomplished. Another thing is to use the heavy light test, and you heard about that yesterday. In a quantitative way, it is possible to use the heavy light to measure certainly IgA, but also IgG down to very low levels, similar to or maybe even beyond the level of immunofixation. You can also use free light as a measure of how low the disease is. And then you can use imaging to see is there any myeloma anywhere. And so in terms of imaging, the test that we are looking at is PET-CT to see is there any myeloma left. And one of the problems that we have with that right now is that that is not standardized. A PET scan, and I showed you a picture of PET scans first thing this morning, is that you're looking at the spots. You know, the nuclear medicine folks are looking to see is there a spot of myeloma. Now that's not so strongly scientific, and so they use something which is called a standardized uptake value, SUV, to see is there strong uptake there or not. And so we need to have a cutoff to say is the PET scan positive or negative. And this has not been established internationally to say that we have a clear SUV cutoff for a positive scan or a negative scan. And we actually have the team from Italy in Bologna working on this. Dr. Cavo and Dr. Elena Zamagni are looking at this to try to come up with a standardized way to have a positive or a negative PET scan to help us with number 3 here. I just want you to be aware, as far as the sequencing goes, what we hear about here in California is the Sequenta method, because Sequenta is a company that's based in South San Francisco, and they do have a method for sequencing. But there are other companies, and they're also homemade. You can do it in your garage if you want to, really. There You need a few bits of equipment in your garage, but you can do it. And so this is not a standardized methodology right now. And as I'll show you, one of the problems with sequencing is that you can't get it to work in every patient. About 12 to 15% of the time, you can't get this technology to work. And the second thing is it more sensitive than using this flow method, which is what we've been studying? And so one of the first parts of this project was to review grants and proposals from different groups. Okay. And the group in Spain, under the direction of Jesus San Miguel in Salamanca, he's more recently moved to Pamplona, where they have the running of the bulls. I think his hospital's not right down by the bull area. But they have a very sensitive method for measuring with the flow method. And so we basically established a research grant program with them to work harder to come up with a more sensitive method for running the cells through the flow machine so that we could pick up, this means 1 in a million. So if you would be able to pick up if there's 1 in a million myeloma cells there. And this is much better than having a pathologist come back from the coffee break and look down the microscope to see if he can see any myeloma cells there. This is a very sensitive method, and it has 2 parts to it. One is that they used a different cocktail of antibodies to detect what's on the surface of the myeloma, and so they came up with a new cocktail to detect the myeloma. And they also came up with several enhancements to detect the myeloma. So up to now, the way that myeloma has been detected is to compare it with the normal marrow, so that you run the cells through, and then you ask the question, is this myeloma or is it normal marrow? So you're comparing myeloma with the normal marrow. What they have done is that they have established a computer database, and they've said, this is what myeloma is. And then they run the cells through, and then they say, is this myeloma or not? So they're comparing the cells with myeloma or not versus normal or not. And this has turned out, using a computer file with thousands of cases of myeloma now, this is a much more efficient way to identify, do you have myeloma or not? They have been also looking at different machines with different numbers of colors. It's amazing, you can use 8 different colors on the same cell, and so it's like all the colors of the rainbow to detect and sort out the patterns. And the best way to do that is actually with what's called multi-dimensional software analysis. And so part of this team is a high-level computer team. Although when we visited Salamanca, we asked to see the guy who was working on the computer program. And they said, oh yeah, he's actually in here. He's actually, if you go over towards that back window there and then in the little corner. So there was a little guy, he had a desk about the size of this, and he was working on the software program. But he'd been working on it for a couple of years. And he came up with a computer program that allows this to be analyzed in 12 minutes now. So this is what is called real time. So you can run the cells through and you can get an answer, a very precise answer. And so this has been a very successful part of this project. And so we have a protocol which includes 8 colors. And then these are the antibodies that we use. An important thing for you to be aware of is that these things which are on the surface of the myeloma can be the basis for diagnosing the myeloma, but also treatment. So if you look at these numbers here, I'll just mention, so this is CD38. So we have anti-CD38 against, so you identify the myeloma that is positive for that. But you also have CD138, which is another one, CD56, and then this one is CD19. All of these are the basis of treatments for myeloma. So you can identify the myeloma, and then you can also identify the density or the amount of those antibodies in thinking about whether it would be a good target to treat or not. And there's a 2-tube method here, and then this is the 10-color method. So they're studying all of those details. Right now, the idea is that if this is going to be an efficient way to look at myeloma, then people around the world need to be able to use this test to figure out how well the treatment is working. So there needs to be a method that can be widely applied. And so fortunately, this flow cytometry, this flow method, is available at all the different hospitals mostly. All large centers have flow cytometers. They use them evaluating a number of different diseases. And so right now, in the US, these are the teams that are using this 8-color gold standard method. And then it's also been adopted very quickly around the world. So we're very excited about this because this means that we can move to the next stage now and evaluate all kinds of different treatment protocols to see if we're getting an MRD negative status. So the question is, if you compare this next generation flow, which is convenient, it's widely available, it costs about $100, $150. The sequencing costs more like $1,000, and most people would be sending it off somewhere, so you would not get the result right away. The flow method, you have what's called real time, where you could run it down the hall and you would get the results that same day. If you look at what we have so far, and we're looking at both. We've been evaluating the sequencing and we've been evaluating the flow. The NGS, the sequencing, we were only able to get it to work at the very low levels. The Spanish team, they've studied, it's not on this slide, but they've studied 275 bone marrows so far. But looking at the very, very low levels where there's maybe only 1 in a million cells left, comparing whether the sequencing is better than the flow, they were able to get the sequencing to work in 14 out of 16, which is 88%. So 12% they were not able to get it to work. But from our standpoint, what was more important is that they look here, this is the NGF, the flow was positive, and then it was negative. Two patients out of the 14, which is 14%, were positive with the flow and negative with the NGS. So from our standpoint, it means that the flow is at least equally sensitive. And we can get it to work in every case, whereas here that you can't. So we're very pleased that we have a method that's good, we can apply it all the time, and we're continuing to compare it against the sequencing. So you have to indulge me a little bit. I just like to show you the swans everywhere, see? So we've got swans in the US, we've got swans in Europe, and we got swans in Asia. We even have a swan down here in Australia. So Dr. Andrew Spencer in Melbourne, Australia, he has integrated the MRD testing into a trial with carfilzomib, thalidomide dex in Australia. Sorry? Okay. The question that was illustrated by Jean-Luc Harrisseau was complete remission. How good is the complete remission, and what is the value of transplant or consolidation for patients who are in complete remission? And this shows you here, when you use that MRD test and you look at patients who are in complete remission. So if they have a complete remission with induction or with transplant, would there be any value to get rid of this noise? Would there be any value in going deeper? And this tells you right here that there are positive, about half of the patients are MRD negative, but 51%, if you go deeper, you will find myeloma. And so if you put this in the form of an iceberg, what that means is that this is what we're seeing right now with complete remission. But if you go deeper to this level, all the way down to 1 in a million, you will pick up lower levels of disease. But you can also see that most of the myeloma is kind of just right below the surface. So we're actually pretty close to eliminating most of this iceberg. You can see that there's a little bit down at the bottom here, but actually most of the disease is in this upper area here. So this gives you some encouragement about how much deeper do you need to go to get rid of what's left. The percentages, 22% just underneath the surface, another 20%, 8%, and just a tiny amount right down at the tip there. We've been trying to get the colors right so we can see all of these, so it's not perfect yet. Sorry about that. If you look at an individual patient, and again, this is what Jean-Luc was talking about, you can see the impact of, this is what happens at the MRD level when you take 3 to 4 months of like CyBOR-D or VRD, then you can have some MRD left. Then you do your high-dose melphalan and stem cell, you get it down to here. Then you do your consolidation, and then you get it down to here. So you can actually document how much added benefit, how much farther down the iceberg are you getting with each of these different steps. So we now have in place the ability to assess what we're doing with these different therapies. And so different trials are cropping up globally, actually. People have realized that they can now start looking at myeloma in different ways. And we are supporting already several trials looking at these different aspects, which I'm showing you here. So the first question is, if the MRD is negative, are we confident that we could stop and just monitor? Or, like the French right now, should we maybe maintain for maybe a year or so and then stop, monitoring the MRD alone? In the IFM trial, about 14% of the patients improved further during that 1 year of maintenance. And so then we would see, do we need to continue longer, or we can safely stop there. But a key part of this Black Swan project now is to study patients who are positive and have residual disease. And for them, there is a need to understand the nature of the cells which are resistant to the current therapy. And so several groups who are part of this Black Swan team are looking at the myeloma in this residual disease setting. So the first thing that's come up in the discussion is that some patients can do just fine, even although they have some myeloma left. And this appears to be related to the fact that they can have what's called an MGUS-like signature. In other words, they've kind of reverted back to the MGUS, which can hold steady, even though it's there, but it's not doing anything. And so you can identify that using the flow machine. You can use the flow machine, and about 10% of the patients show that. You can also do it using molecular methods, using this what's called GEP, where you can have the pattern of the genes that'll tell you the cells that are left are green, which is this MGUS, or the cells that are left are active myeloma, which is these red ones over here. So you can tell that maybe it's MGUS and maybe you could stop, or it's red and maybe you need to find out more about that. This is, we can skip this really. This is just to show that for those patients that have the MGUS signature, even although they don't have a complete remission, the survival is good. They don't need to get into a complete remission. Of the patients who have residual disease and it has the pattern of myeloma, several groups have started to look at what is the pattern related to the treatment that they have had. And so the question is, if they have had Velcade and there is myeloma left, do they have a pattern of where the cells which are left are resistant to Velcade? And see here, this is the pattern at the start of the treatment, and this is the pattern at the MRD point. And you can see that they have more red over here. And so the question is, what is that red? And so in the case of Velcade, what has been found here is, and this was presented by Dr. Bruno Paiva from Spain at ASH, and has been published actually now, that this is a proteasome subunit. So basically, the cells can kind of sneak around the Velcade therapy and become resistant to it. So obviously, this is very important to come out with what treatment should be recommended. You can also look at the pattern of what is on the surface of the myeloma. What we know right now is that when the myeloma is when you're starting on treatment for myeloma, you have 5 or 6 subclones. So it's not just one collection of myeloma. There are 5 or 6 variations on the myeloma. And so at the MRD point, you might have 1 or 2 clones left, and those clones are not the same as they were at the beginning. And this is looking at some of the surface markers, and this is a system which is called the checkpoint area. Are the cells being controlled by the immune system or not? What is the pattern of what's called PD-L1, PD axis, which is the control mechanism between the T lymphocytes and the myeloma? And what has been found here is that, I won't go into all the details, but basically there is an increase in this regulatory mechanism in these resistant cells. So this could be a target for treatment for the resistant subclones. And so the idea is to look at the immune level, and as I'll show you in a second, at the molecular level, to see for the residual cells, what would be the targets for therapy. And for us and for you, it is incredibly exciting. Look at all the targets, including the sign at the back, that are available to treat the residual myeloma. In this box right here, you have the green dots, and those are the surface patterns where we already have treatment. And so here we have daratumumab and the SAR compound against CD38. These are areas where we already have drugs that work. Over here, there are treatments that can work frequently in combination. And then the CAR T cells, we'll talk about these therapies later in the day. As far as the molecular, we have a number of targets, but our ability to treat that is currently much less, but we're looking at those patterns. In addition, Jean-Luc mentioned that we have the response criteria. Using this, we're switching the response criteria. Right now, we go from complete remission to stringent complete remission. Now, we're moving over to MRD negative, and what this means is that we're actually going to get rid of stringent complete remission and use MRD negative as the new target for therapy. And we're using definitions for molecular, flow, and the PET scanning, which needs some work, but we're aiming for that. And so this is exciting. We have upcoming trials where we're actually looking at a blood test. So instead of sampling the bone marrow, you'll be glad to know that we're looking at several different types of blood tests to assess this. I know, you'll be disappointed. No more bone marrow. I'm sorry. We can take it in the blood. And so we have some exciting information on that. And we're using that as a basis for decision-making in the smoldering area. So we have data, for example, that using a blood test, a single blood test, we could identify the patients with smoldering myeloma that might be active and are candidates for therapy. And then over here, I've already mentioned, there are 3 possibilities as the area of MRD. It can be negative, it could be MGUS, or it could be resistant. And obviously that would be the basis for different treatment options. There are 2 trials. This trial has already started in Spain, and this is called the CAESAR trial. It's a curative strategy, which is Spanish for strategy, smoldering, and then alto, which is the Spanish for high. So it's a curative strategy for high-risk smoldering. And this is using carfilzomib, Revlimid, and Dex. It's using stem cell transplant for smoldering myeloma, and then with some maintenance, consolidation and maintenance here. So a very aggressive approach. There's also a US study, which will hopefully start later this year, very similar, where we are in addition adding in daratumumab in the induction and the consolidation. And the idea is to really eradicate disease in patients with high-risk smoldering. The other point, just to end with, is that we're looking at getting rid of the myeloma. What we've also learned, though, is that there is a unique immune signature. And so as you get rid of the myeloma, the normal immune recovery shows a particular pattern. And that there are increased numbers of Treg cells, regulatory T cells, of a type called Treg number 17. So there's a pattern that occurs in patients who have had a low level of myeloma, have stayed in complete remission for a long time, and then have reconstitution of their immune system. So that's going to be part of the equation. Myeloma down, normal immune system up. So we have a very ambitious plan. We're very excited that we're making progress. We're down to some key steps here. We're at this stage here. We're very keen to come up with a blood test. We want to understand MRD negative. We want to have therapies to get rid of MRD positive and then move forward from there. So hopefully this gives you a good idea of what this is all about and how excited we are about the progress that we're making. And so as compared to first thing this morning, I've moved the myeloma over here to a rock where he's got a spotlight on it. The swan. The swan was in the shade, and we've now moved him into the light. Thank you.
Could you go over it all one more time?
All right.
Question? Go for
I
it,
have a
Cal.
question here.
All right.
With horror that Cedars-Sinai was not on the list, when will we have the NGF 8-color gold standard here in Southern California?
The first place that will probably have it up and running is City of Hope. And so we're working with them. So I think that right now that'll be the place. And I'm hopeful. The machinations at Cedars are such that I want it to happen, and maybe we can get it to happen. Have they set it up with the new method yet?
Here, hold on, Bob. Susie,
We'll get you a mic.
Because I did talk to them a few months ago and told them about the need for this assay, and so they've set it up to my knowledge.
So yeah, we will definitely try to help them to get it up and running. It's one of those things where there's a difference between the doctor in the clinic and then the doctor in the lab. So we talked to Bob and he says, great, we'll set it up. And then we call the lab and then they don't call us back. Okay.
Okay, question over here.
So you mentioned that you could have either MGUS or smoldering, then the disease progresses, but then after treatment you return to sort of back to an MGUS state. And then in Dr. McHale's presentation, he talked about if MGUS you're not really doing anything. So what are you when you're sort of this back to MGUS?
So what was that last? What are we?
When you've had treatment and you return to what you call an MGUS-like state,
right?
Are you treating that as if it's MGUS, or are you treating that as if it's an active disease?
So the importance of identifying that is that it's a type of patient where we would feel more comfortable to stop therapy and watch, and on the opposite side, where it's not a good idea to give more toxic therapy to get rid of it because probably it's going to be holding steady. But I mean, I'd be Is Dr. McHale still here? Yeah, so you want to comment on that subset where if you had an MGUS signature, maybe you would stop versus treating?
Sure, thank you. So it can be viewed in different ways, but what we think is probably happening, we see a bit more of it in the hyperdiploid states, is it could be that someone has more than one clone, as Brian described, and one of them is kind of an MGUS-like clone, very, very slow growing and probably never means anything. And then there's some additional ones that grow that are true myeloma. So you treat, the myeloma ones disappear, at least temporarily, and that little MGUS one is left. Remember I commented in my presentation, we have some patients, ironically, that may live the longest of myeloma, and they're never in a complete remission because there's always this little schmutz of MGUS clone that hasn't left. And so in that situation, those are the people that we don't really want to treat, because that's like treating MGUS. You're really treating the dust that's in the corner that's not affecting anybody, and it's only going to introduce potential toxicity to the patient, not help them. This all theoretically sounds delicious, but it's hard to know when you're looking at a patient to know, is this your MGUS clone that's left or the other clone? With some of these techniques, we hope to be able to identify that a little bit better. But it's a complicated disease. That's not the way it is with everybody. There's some people where it seems to be just one clone. There's some people where it's a rapid-going clone, et cetera. So it's not that simple, but we do think that with this kind of testing, if we end up having someone that has that little MGUS clone that's left, we probably won't treat them because it's not likely going to change their outcome.
Right. But thus far, what we're seeing is that typically you might go from 5 or 6 clones, as Joe just said, to maybe 1 or 2 clones. And so you might have a couple of clones left.
Doctor? Hi. Until recently, my impression about minimum residual disease testing has been that the main use of it is as a new endpoint for clinical trials, so that we have a way to measure the disease to a much more sensitive level, and possibly be able to tell whether it's cured. But from a remark Dr. McHale made earlier this morning, I want to ask, has it gotten to the point where, at least at some institutions and maybe for a certain subset of patients, it's used outside clinical trials to help determine the course of treatment for those patients? Or is it still just in clinical trials?
Okay, so maybe we can both comment on that. So I didn't show one aspect of the black swan, which is to start to use the MRD as a primary endpoint, as you're saying. So if you have 2 treatments, and one of the treatments gives you 40% MRD negative, and then another treatment gives you 20% MRD negative, then the one treatment would be better than another, okay? And so within trials right now, for example, in the ECOG trial, in the Endeavor trial, Dr. Shaji Kumar is doing MRD in Kyprolis dex versus Velcade dex. And in that study, it will be what's called a secondary endpoint, where we'll see what is the MRD. If the FDA ends up being convinced that this is a reliable endpoint, that the difference translates into a longer remission of at least 6 months or survival of at least a year, then this could move into a position as a true primary surrogate endpoint. And we're definitely aiming for that, okay?
Yeah, Brian, I would just comment that, you know, I hope I didn't say too prematurely this morning, but I think it's safe to say we're not at a stage yet where MRD testing is really changing what we do every day in the clinic.
Right.
But there may be a small percentage of people. We've heard some of the discussion today about maintenance therapy, to maintain, not to maintain. Should everybody go on maintenance therapy? Should someone who has low-risk disease, who's in a complete remission, go on maintenance therapy? We have a discussion with our patients, and I suspect that right now there'll be a small subset of them that are in complete remission after a transplant, who are maybe leaning towards, maybe I'll just take nada for a while, maybe I'll just wait and watch. If I told them in addition, oh, and by the way, your complete remission is MRD negative, that might even further, no pun intended, consolidate their decision, right?
Right.
It might further enhance their decision, whereas if there was still disease positivity, because some places are taking the approach that in general we're using maintenance therapy, but maybe in the exception of a few people who are really in a deep response,
who have low-risk disease, maybe we can just wait and watch. So that's maybe the one place right now, because
Right.
some of the Spanish studies did show, looking at that at the day 100 visit, as it were, not just your cytogenetics, not just other ISS-like factors, but your MRD status could predict prognosis down the line. So I don't want to make it sound like we're using it routinely every day, but I think in that small subset, it's just one other small piece of information that might influence us one way or the other. But I don't want people to feel like, oh no, I'm not getting this testing and therefore something big is missing in my clinical care, because it's really not the standard of care, and it won't be until, as you described very well, Brian, it's well documented in larger trials, and is FDA recognized.
So the whole Black Swan project, as far as the clinic, is in the form of trials. We need to understand what negative means. We need to understand what positive means. And so we are absolutely not recommending it in clinical practice right now. And we're actually quite anxious about the fact that as we are standardizing the method and it becomes feasible to do it, that decisions will end up being made. The first thing is to standardize the method, so that, and this has been a big problem up to now, but we've basically described the recipe right here, and if this becomes standardized, this could be a basis for decision making. But right now, I think it would be a basis for prognostic assessment mostly, where obviously if you're MRD negative, we would be very pleased, but we're a little hesitant to recommend any changes.
Okay, Suzanne's going to wind it up with one last question.
Right here.
All right.
It's actually a follow-up to what we were just talking about. It sounds like if you have high-risk disease, then in terms of the clinical implications, it really wouldn't have any at this point, because if you would only possibly use it in a low-risk situation, then it sounds like for a high-risk person, there'd be not any clinical value to doing the test at this point. Is that correct?
Right now, yeah, we're not using it in the clinic, partly because the standardized test is not available, and also because we don't have enough trial data to make a decisive recommendation. But a year from now, 2 years from now, I can see where it could be quite widely used, and that's why we're focusing on a method that could be widely used once we understand what it means. And then it could be used in high-risk patients, it could be used in low-risk patients. I could see a lot of use for this. The other thing is that truly, if we can get it to be useful as a blood test, this is going to be much more valuable and much more broadly applicable. And so you can see that this whole area of research is moving quickly. This is just in 2 years. But it's not quite into the clinic, but I think that once it gets into the clinic, it could be very widely used.
A second question is just, did anybody look at genetic risk compared to whether or not there was MRD present? You know, you said there were 50-50.
Yeah, so the several teams, the Spanish and then also the UK team, the MRC team, the group in England have looked extensively at this. And so basically, to achieve MRD and to sustain MRD is much more likely in patients with good risk disease. So in terms of our ability to cure myeloma, our ability would be to start early, and then our best chance would be in patients with good risk disease. But our ability to find out what would be the best drugs to get rid of every last bit of myeloma, that will probably come from studying high-risk disease. And those protocols in high-risk disease with new drugs and new combinations will be incredibly helpful to use earlier. All right. I think, is it?
Carmen, it's time for Carmen.
Yep, lunch announcement. So lunch is going to be where you all had breakfast if you were able to join us early this morning. It's just down to the right here, down the stairs. And we'll be back in here at 1 o'clock to resume. During lunch, if you'd like to sign up for the breakouts, the board is to your left by the bathrooms to sign up for the breakouts. All right. Thank you.
Thanks very much. Oh, okay, we're going to get started shortly. So those of you coming in, if you want to go ahead and take your seats, we'll start momentarily. So there's a few more people to come back from lunch. All right, it looks like most people who are coming back from lunch came back from lunch. All right, so if I can have your attention, we're going to get started. All right, thank you. So I hope that you enjoyed lunch, and I don't know how much real food was there, but hopefully it was mostly real. I'm very pleased after lunch to have Dr. Bob Vesio from Cedars to present. Bob has had a number of interests over the years. He had an important interest in stem cell transplant and obviously is involved with the stem cell transplant program at Cedars. Obviously, he also is very much interested in bone disease and was involved with a number of the trials in the years where we were evaluating the bisphosphonate therapy, Iridia and Zometa, and the value in the treatment of bone disease. And more recently, Bob has also developed a significant interest in amyloid, and so has an amyloid clinic at Cedars. And so he has several areas of interest. But today, Bob is going to be talking about bone disease, which is important for many of you. So please welcome Dr. Vesio. Hey. All right. All your fans are here.
Yeah. All right, your checks will be coming later.
Yes, yeah, we'll get the payouts later, yes.
Well, thanks, Brian. Thank you very much for inviting me to come, and it's always a great honor to be at this meeting. It's a wonderful meeting for everyone, and really the questions that get asked are excellent, so I learn things from all of you as well as we go through this meeting. So I'm going to talk about bones and some of the supportive care for patients with multiple myeloma. Let's see, make sure I can do this right. And so multiple myeloma is inside the bone marrow, but as it grows, it can damage the bones where the cells lie. It can kind of invade and kind of take over the inside of the bones where we make our blood and cause low blood counts. And then finally, the protein that's produced, the light chain protein in particular, can damage the kidneys. So controlling the disease is important. Not everyone, which is probably surprising to some, with multiple myeloma has bone disease. Only about 85% of patients will ultimately have problems related to their bones. When it does occur, it can cause pain, and people can feel like an ache that doesn't seem to go away, and ultimately can have fractures from the bones getting weak and breaking under stress. And the myeloma cells can maybe directly damage the bones, but more commonly it's indirect. They stimulate the surrounding cells, the main one being the osteoclast, which then dissolves the bone, making it weak and then resulting in a fracture. So this is kind of what the inside of a bone looks like, and this is a vertebrae in their spine, and the outside part is kind of what gives a lot of the strength, but that inside honeycomb area is where the myeloma cells are, but that's also where the healthy bone marrow is. That's the marrow of the bone, and that's also important for the strength of the bones. And believe it or not, our bodies are always breaking down bone in addition to making new bone. You would think the body would want to just make as strong a bone as it could and then just leave it at that. But continuously through our lives, the body breaks down bone where it's not needed and kind of measures that based on stress that's applied, and then puts down bone where it is needed. And kind of the analogy, especially it's making the news lately, and somebody else put together this slide, but kind of the analogy is, you know, the potholes that we have quite frequently throughout Los Angeles. And there'll be an area where, you know, the street needs repair. And so what's first done is you dig out a hole and you kind of take the whole area out, and then you fill it back in with the new bone, and hopefully years later there's no more pothole. And the way this occurs in people, in the bones, are these cells called osteoclasts. They look kind of like a Pac-Man, and they go in and chew away the bone where your body doesn't need it. Old bone maybe, or again, areas that aren't necessary. And then what comes afterwards are these osteoblasts. Those are the cells that produce and lay down new bone, and then ultimately you're left with this brand new area of strengthened bone. And kind of this is a disheartening slide, but you know, I just had my birthday. I thought I wasn't that far over the hill, but as far as our bones are concerned, you know, everything's downhill from about the age of 25 or 30. And your bone strength, just in most people, gradually deteriorates, more so in women, particularly after menopause, but in all of us as we get older. And what happens is, in a normal person, well, normal in their 20s, that honeycomb structure is dense and helpful to support the kind of outside part of the bone. And as people get severe osteoporosis, you can see that kind of honeycomb pattern breaks away or shrinks, and it makes the bone weaker and more likely to fracture. And it's within these kind of pockets, again, is where the myeloma cells, are made. So what happens when people have multiple myeloma? Well, way back over 100 years ago, Dr. Paget kind of came up with this concept that, you know, tumor cells need something to support them, not only physically, but also with the hormones that make the tumor cells grow. And in the concept of seed and soil, the myeloma cells are the seeds, but it's incumbent upon the soil. There's fibroblasts, even those osteoclasts that can secrete hormones that make the myeloma cells grow. It's much less common for these myeloma cells to be growing in the lung or in the liver, for that matter, because they don't get the nutrients in those areas like they do in the bone marrow. And if you look under the microscope, those cells in purple would be the myeloma cells, and those big red blobs there are those osteoclasts that look like the Pac-Man, and then this pink, light pink material, that's the bone. And so together, things are occurring, and it turns out that it's a vicious cycle of kind of one helping the other in a bad way. The myeloma cells secrete hormones that stimulate these kind of supporting cells. The non-fancy name for them is bone marrow stroma. And those stromal cells secrete hormones that stimulate the osteoclast. And the osteoclast, which chews away on the bone, actually makes hormones, interleukin-6 being one of them, that makes the myeloma cells grow. So if you kill those cells, these cells won't grow as well, but maybe if we can kill some of those cells, the myeloma cells won't grow as well either. So when people develop multiple myeloma, it's not always evenly distributed through the body. Most of you looking at this x-ray would say, well, you're not really supposed to have that hole looking like area there, and that is not normal. That would be an area where the myeloma cells have weakened the bone. What's important to recognize is that even 10 years later, that bone area, that area may look the same. It's where the kind of the myeloma cell termites kind of have chewed away the wood or the bone in that area and left it weak. It's hard to break your skull, however, so even though that looks pretty bad, it's much worse to have this one right here because it's not so hard to break your arm, and that's the one we would have to worry about. The other areas we frankly have to worry the most about is in the spine, because already, you know, the body isn't designed so well where we have a lot of, you know, excess strength in the bones in our spine, and you can see somebody here with their myeloma, it's weakened that side of the bone, and you can imagine how it wouldn't take much for that bone to collapse. And in fact, that's what happens. And when that occurs, it's painful, just like any broken bone would be. And it also can change someone's posture. And by changing the posture, it puts weight on different parts of the bones where your body wasn't made to put weight on it. And that can be painful. And then if it's bad enough and you've collapsed the bones enough, it's hard to expand your lungs, because if it's like an accordion, you kind of collapse the spine, there isn't room for the lungs to expand, and I've had patients permanently feel short of breath because they can't inhale and exhale air as well as they used to. So it's important to try to keep that from happening. Now, this isn't the best slide. One day I'll get a better one, but what's important to know is that the myeloma cells don't spread through the body the same way in everyone. Some patients, the myeloma cells are kind of evenly distributed. So, like, you know, the lawn is kind of evenly distributed through with weeds, and that would be this person over here where all the bones, you could tell, are abnormal with the myeloma cells. There are other patients where it's a little more spotty, but it's in most of the areas, and no matter what bone you would stick a needle in there, you would still find it. And then yet there are other people that have normal bones here, but then have a lot of myeloma up there. And it's very focal, so they can have, you know, and I've had patients where they would have a tumor pop up and they would have a bone marrow biopsy, and the bone marrow biopsy would show no myeloma, yet they would have tumors growing somewhere else in their body, and it can do that within the bones as well. So what can happen when people have these bone problems? Well, a medical way of calling it is a skeletal-related event. It's a term that's used to describe kind of the bad things that can happen to the bones, like a fracture, spinal cord compression. That's where the tumor and or the bone presses on the spinal cord, and that's kind of the thing we want to avoid the most because it can cause paralysis. If somebody needs radiation treatment, the assumption is, well, they needed radiation therapy because they were in pain, there was some problem there, or if somebody had surgery to their bones, that's the same kind of concept. So all these things you're trying to avoid if one can. So how do we deal with these problems? Well, frankly, by far, the most important thing is to fix the myeloma. If we fix the myeloma, the bones aren't going to get worse. So that's still the goal, and I can tell you from my career, from the first patient I saw 20-some years ago with myeloma, that where she, at the VA, if she even rolled over in bed, she might break another rib. We just don't see that anymore, and that's for many reasons, but part of that is because of these bisphosphonates, which I'm going to talk about, but also because more people get good treatment and get good treatment right away, and it puts their disease in control, and their body has a chance to heal and recover from the cancer. If the vertebrae in the spine collapses, one of the procedures that can be done that can help with pain
is called a vertebroplasty. This needle kind of looks like a bone marrow biopsy needle. It's kind of done like a bone marrow biopsy. They put the needle in the bone in the spine, and then you can see it within there, and they inject this. It's not really cement, but it's we kind of view it like cement into the bone, and it stiffens the bone, and oftentimes that can help people's pain. What's done, I think, a little more commonly in this country, it's called a kyphoplasty or balloon kyphoplasty, and the same kind of needle is put into the bone that's collapsed. Then a balloon is put through there and inflated, which has some advantages. It can kind of re-expand that vertebrae, and then the balloon is taken out, and basically some cement-like material is put into that cavity. And it's a little more controlled, and it has the advantage of possibly helping somebody's posture along the way. So it's people that I kind of mentioned that should be done for them, get nervous. It's like they've all heard of somebody who had back surgery, and especially from 10, 15 years ago, that can be a bad thing to go through. Doesn't always work. This is not so surgical. It's a much more benign procedure. There's little incisions, 1 centimeter incisions. Takes about an hour per fracture that's treated. And most people just go home the next day. I don't know that I've had anybody have to spend the night after the procedure. And just to kind of give you an example of how this can work, this was a study from a while ago where they treated 63 patients. They did 264 kyphoplasties, and probably most of you know that pain scale that the nurses always ask you, like on a scale of 1 to 10, how bad's your pain? 10 being childbirth, 1 being something less than that. So if the average was 6, after the procedure, it averaged around 3, 2.8. Now, it's deceiving, though, those numbers, because that sounds like everybody gets better by 50%. The reality is that some people get tremendously better and the pain goes away, and other people go through the procedure and get no benefit at all. And it's just it's a waste of time for them. And it is hard to totally predict, but usually if the pain's coming from the area where the fracture is, and the fracture was kind of new, and there it is on the MRI, then there's a good chance that the procedure can help. But some people have pain coming from lots of areas, and we don't routinely do kyphoplasties on 8 or 10 vertebrae to try to fix them all. Radiation is a great treatment for multiple myeloma as far as killing cells, but it also injures the bone marrow. So I think it's important to use it sparingly when you have to. So if you have one area that's a problem, it can fix it. The problem is if you treat a bunch of areas that way, you can be left with your healthy cells not being produced the way they should, chronically anemic or have low blood counts. So it's used particularly for those patients that have solitary plasmacytomas, because for those patients, the hope is that they have one tumor, and you treat that one tumor with the radiation, and that'll kill that tumor, and hopefully that was the only one that in the body. So medically, what we can do is give these drugs called bisphosphonates. They aren't a direct treatment for multiple myeloma. We don't think of these drugs as, okay, I'm going to treat the multiple myeloma by using these agents. What they do is they assist the bones in keeping them strong, or probably more correctly, keeping the bones from being damaged by whatever multiple myeloma cells remain. And they basically work on the osteoclast, those cells that break down bone. And a long time ago, and many of you in the room know of this gentleman, Dr. Berenson, he helped initiate and run this study. Was done we were doing at the VA a long time ago, and patients got placebo, so they would very nicely would come into the office and get sugar water, basically, or they got pomidronate, and it was by a coin flip which one they got. And that was because back then, as you can see, this was published in 1996, so the study was in the early 90s. Back then, there was no proof that these drugs did anything. So it was to see if they do help, and sure enough, the people that got lucky enough to be randomized to the pomidronate, which is the generic for Aridia, they had fewer skeletal problems, those SREs, than the people that got the placebo. One thing that I think gets underappreciated, though, by those studies is that it helped people's pain as well. We could kind of tell who was getting the drug because some of them had, a few months later, less pain. But it would take a few months to develop. So the difference in how people's pain was bothering them, there was no difference in the first couple of months. It takes a while to build up, and it took 6 months before people started having less fractures between the two groups. So people in the placebo group, people in the Aridia group were still getting fractures at the same rate 4 months after the study started. It took time for these drugs to build up to a point where they could stop the bones from being damaged. And then ultimately and people still had fractures with these drugs. Especially back then, but a lot of women in the audience may be taking, even if they don't have multiple myeloma, a drug for their bones. Fosamax, Boniva are the trade names. And the question has always been, well, those are easy, those are pills. You know, that's a lot easier than sitting in a chair for a couple hours. The problem with the pills is they don't get fully absorbed. So it varies. Some people, the pill gets in a lot, some people not so much. It's hard to know who's going to be who. And while it may be enough to treat osteoporosis to take those medicines, we've learned over the years it's probably not enough to stop the myeloma from damaging the bone. So we tend to not give those drugs as a main treatment for myeloma bone disease. Unfortunately, these bisphosphonates do have side effects like most things. There's trade-offs. The first ones are that when you first get the medicine, it can make you feel like you have the flu, feel achy, and that can be pretty severe. I would say even more so with Zometa than Aridia. But those seem to get better with time. Most people after their third, fourth treatment don't seem to have those symptoms anymore, but there are exceptions. When these drugs were being studied, it was felt that 1 milligram per minute was safe. So as long as you infused it slower than that, it wouldn't hurt the kidneys. So that's how they came up with these numbers. 90 milligrams of pomidronate, well, 120 minutes should be safe. Zoledronic acid initially, which is Zometa, it's a terrible name, zoledronic acid, but 4 milligrams, it was thought, well, 5 minutes should be safe. 5 minutes wasn't safe. 5 minutes caused kidney problems. 15 minutes is the bare minimum amount of time that you should use safely to receive Zometa. These drugs also, unfortunately, can lead to osteonecrosis of the jaw, and I'm going to talk about that in a few minutes. And there is some concern that, and I've seen this happen, where it makes the bones brittle, and they can fracture from that. So it can be, you can have too much. So compared to the old days when etidronate was around and wasn't used so much, pomidronate is 100 times as potent as that. Zometa is 100,000 times as potent as etidronate if you use 1 milligram of the first one versus a milligram of zoledronic acid. And you can see zoledronic acid. So you have to use a lot more to have the same effect. The hope was that this newer drug, Zometa, zoledronic acid, was going to be much better than Aridia at preventing bone problems. And this was a study, it included actually mostly women with breast cancer, but you can see in red it was a little better than the pomidronate, than the Aridia, but not by a lot, and not enough so that where the government and most of us believe you can use either one, they both work. And so it really just comes down to convenience and maybe cost sometimes, which insurance companies will allow you which one to use. The problem I think we still have is we don't know what to do after 2 years of treatment, because all these studies went for 2 years and then the study was over. It was a mistake, really, because what do you do with the third year? What do you do with the fourth year? And frankly, when you don't have information, then we can all sit and give you our thoughts, but we're just giving you our thoughts and what maybe makes some sense without being able to tell you conclusively, oh, it's better to take 4 years of the drug or 2.5 years or only 2 years. People wonder whether you still need it if you're in remission. And maybe, I would argue just quickly that maybe you don't if you knew your disease was never going to come back. The problem is if you wait till it comes back, it takes a while to work again. So I've seen people get into trouble when they haven't had these drugs for a long time and their cancer comes back and it hurts their bones. It does increase the risk for osteonecrosis of the jaw, and I'll talk about that. And there may be some urine tests that can help us decide what to do, but frankly, they're not that good. So the most important study, I think, lately was this one. It was a huge study, almost 2,000 people in England, and they were treated with their regular therapy for their multiple myeloma, but as part of that, half the people took Zometa, and half the people, got tails, and they were given clodronate, a drug that was shown to be better than placebo in England years ago when the Iridia trial was being done. So Zometa versus a big dose of clodronate as a pill, but it's every day. So not as potent a drug, but a lot of it. And the people getting the Zometa had less bone complications. It cut the chance of having a bony problem by 24%. But more surprisingly, I think to all of us, was that it seemed to reduce the chance of actually dying of the disease, dying of multiple myeloma. Cut the chance by 15%, 16% compared to those taking the clodronate, which translated into about a 5.5-month survival advantage for those people who, by coin flip, got chosen to take Zometa over the clodronate. And so this gave us thoughts that maybe these Zometa has some anti-cancer effect, maybe by working on those soil and indirectly slowing the growth of the seeds, the myeloma cells. It comes with a cost, maybe probably financially too, but cost medically, in that the Zometa caused osteonecrosis of the jaw. Not often, but definitely more than what you saw in those people who took clodronate. So that's the trade-off. No difference in kidney problems, though, between the two. So osteonecrosis of the jaw, or ONJ, can happen in people receiving these drugs. It's more likely to happen if somebody's had radiation to their jaw, because that also injures the blood vessels going to the bone. It can kind of show itself in two ways. It can either be an area where a tooth gets removed and then the gum never heals over, or sometimes there's like some trauma in the gum and the piece of bone kind of shows itself through the gum, and then again it doesn't seal over it. And it can be painful. People can complain of discomfort, and it can definitely be a nuisance, if not a major nuisance, for patients. I still don't think people totally know why it happens. I think, the jaw is more susceptible to infection. It's hard for me to get my humerus infected with bacteria because it's buried under my skin. But your teeth go straight into the bone, and particularly if you have an infected tooth, but if they take a tooth out, the bacteria can instantly seed the surface of the bone and lead to an infection. And osteoclasts are needed to kind of dissolve the bone for your body to get rid of the infection. So how do you keep this from happening? Well, the most important thing, again, is prevention. Keep your mouth in good shape, get good oral hygiene. Things that make your mouth dry make it more likely. That's one reason people think myeloma patients get more dental problems, is a lot of these chemo drugs kill off the salivary glands, and it makes people get dry mouth, and people with dry mouths are more likely to get dental problems. It's good to be seen by a dentist, to have them kind of follow up on you, and fortunately it seems like it's better than it was 10 years ago. 10 years ago I would have patients go to a dentist and they'd hear they were on Zometa and they'd say, well, I'm not touching you. and they would send them back home. And that's the wrong thing to do, because preventative dental care can prevent a lot of these problems. If somebody needs a tooth removed, then you need to work with your doctor, your oncologist, to kind of help prevent a problem. And a lot of times antibiotics can be helpful for that. There's some other drugs in the pipeline. I'll mention it because there's a big study going on right now. There's a drug called denosumab that blocks the signaling that makes osteoclasts turn into these Pac-Men. So it's an antibody treatment. It doesn't hurt the kidneys, so presumably it's safer. In that way, it's a little easier, quicker to give, a little more expensive, unfortunately, but it's given monthly. It was compared to Zometa, and it was a little more effective at stopping bone problems. The problem was that if you looked at just the few myeloma patients that received the drug, they tended to have a worsened outcome for their cancer than the people that got the Zometa. So people argue it just wasn't enough patients to really answer the question, but because of this result, the denosumab is not available in this country to give myeloma patients, although women with breast cancer, men with prostate cancer can receive the drug. Unfortunately, the hope was it wouldn't cause this osteonecrosis of the jaw, but it still does, and in fact was a little bit worse than the Zometa in doing that. So in summary, as far as the bones go, by far the most important thing is preventing a problem, because you're trying to deal with a broken bone or markedly weakened bones is a lot harder to fix. It's hard to make bones stronger. It's a lot easier to keep them from getting weak. And controlling the myeloma is important, but ambulation, walking is important. The people in outer space floating around in the space station, they lose bone mass, and it's definitely an issue for them up there because they're not kind of pounding on pavement, which sends shock waves through their legs, which tells their legs to, their femurs to be strong where those impulses are going through them. And so presumably they're going to have to take drugs to mitigate that problem. The bisphosphonates are helpful. They definitely, again, are an important part of the treatment for multiple myeloma. Vitamin D often can be low. Vitamin D is important for bone health. So having that checked, and if it's low in particular, having that replaced. And then we have these other things to do if the bones are in trouble. So in the last few minutes, I was going to talk about some of the other things that can happen for people with multiple myeloma. Obviously, the disease itself can invade the bone marrow and result in low blood counts. People are anemic with multiple myeloma even before they've had any therapy, but a lot of the therapies also can cause low blood counts. The cells that fight infection are these neutrophils or polys. Unfortunately, they're called two different names, and those are the cells in the bloodstream that fight off bacterial infections. So I would argue they're probably the most important cells because you can't do well without so many of those, or you can't do well at all without those, but usually you can transfuse these. You can't transfuse white blood cells too easily. And so being neutropenic will make you more likely to get infections. Platelets are kind of the bricks that stop holes in your blood vessels if you cut yourself. So low levels of platelets can make people bleed, and then some of the medicines that people take, aspirin, Coumadin, can make people bleed in combination with a low platelet count. So when people are anemic, red blood cells carry oxygen, so that's what kind of gives the energy to the body, kind of helps the body use the sugar. You need the oxygen, so if you don't have it, your heart has to pump harder to push that oxygen around the body, and so you get fatigued, shortness of breath. Again, your heart has to beat faster, so you get tachycardia, rapid heart rate, and it can even lead to these other problems from being anemic. It's not always the myeloma that does it. I've seen people that are anemic, and it turns out they just didn't have any iron. So giving them iron fixes the problem, but at the same token, just being anemic doesn't mean you're low on iron. There's plenty of people that are anemic that have plenty of iron. It's just the myeloma cells have injured the bone marrow, or have kind of crowded out the healthy cells in the bone marrow, or the drugs have damaged the cells. B12 is a vitamin that's important for the blood as well, so having that checked if you're anemic, because that's a quick fix. There's a shot or a pill even can often recover the B12 levels and fix somebody's anemia. There are some medicines, hormones that can be given. Procrit, Epogen, Aranest, they're shots that are given in the office, and they're basically the hormone the body makes to stimulate the bone marrow to make red blood cells. So it's kind of telling your body to make those red blood cells if at all possible, and so that can help as well. One of the problems that people with multiple myeloma often face is infections, and frankly, a lot of times if people die of multiple myeloma, it's because of an infection. There are certain things that can be done to prevent problems. Vaccines, I know there's a lot of controversy on vaccines, but if you look at the risk-benefit ratio of vaccines, it's markedly in favor of the benefit over the very minute risk that vaccines cause. So certainly influenza, the vaccine for the flu is critical for people. We're not even allowed to go to work if we don't get the flu shot. So that's how important our hospital and epidemiologists believe the flu shot is for all of us. You can give people immunoglobulin. It's kind of cumbersome. It's expensive. But a lot of times when people have multiple myeloma, their healthy antibodies are suppressed because of the treatment, because of the disease. And then so you can collect antibodies from blood donors and pool it together, and it gets treated. It seems to be very safe. And infuse that once a month, and that can kind of augment your immune system and keep people out of the hospital and keep people from having bad infections. And then there's certain medicines that we give, like acyclovir, to try to prevent herpetic and shingles reactivation, which can be common in people with multiple myeloma. Finally, the kidneys can be damaged by the disease itself. And so it's important to do things to make sure you're nice to your kidneys, I guess is the best way of saying it. Don't do things that would harm the kidneys. So things that could harm the kidneys are getting dehydrated. So playing tennis in Palm Springs and not, without any water. Or having food poisoning and getting diarrhea and then just figuring, I'll be okay, and finding out that a day or two later that the kidneys really got damaged by being dehydrated. Certain things like contrast in your veins. So sometimes the doctor doesn't know you have myeloma. You go to see a surgeon and he wants to do some procedure and says, we're going to do a CT scan with contrast. The contrast can hurt the kidneys. So you have to, sometimes it's necessary, but you have to let the doctors know that you have myeloma, that maybe we should try to do without contrast if at all possible. And then drink enough fluids. It's again it doesn't help your kidneys to drink gallons of water, but just to drink enough to where your kidneys are getting have plenty of water and you're not getting low blood pressure that would hurt your kidneys. And there's some drugs that can be given, but you need to be cautious about. So the Aleve, Motrin, and I have patients taking it because that's what works, but you have to be a little more cautious with those because they also can hurt your kidney. So in summary, you have to let your healthcare provider, your doctor know what's happening, keep them part of the loop, and if there's any if you have doubts on what you should or shouldn't do, let your oncologist know what's planned, and then if you have a fever, by all means, get in contact with your doctor. Don't try to tough it out at home. And I'll stop there.
Yeah. All right, careful there. We don't want to have any bone problems. So thank you very much, Bob, for the excellent overview about bone issues and other supportive care problems that can happen. So, yeah, have a seat. I think we have time for questions, yeah. And is Dr. McHale still here? Yeah. And Dr. Harriso, are they still here? Yeah, if you want to come up for questions about bone and supportive care. So, who wants to go first about...
We have one right here.
Okay, right there.
So if you have one tumor on the spine, like a 4-centimeter tumor on the spine, and then multiple lytic lesions through the rest of the spine and the vertebra and such, in the early stages of treatment, what would be the harm of a single radiation dose to the one big tumor? Because that wouldn't affect all the bones, it wouldn't be repeated. I just wondered if it would do harm or might do good.
Okay,
so that's a great question. It's one that comes up pretty frequently. You know, I think if the tumor, people do it differently because we're pretty confident in our treatment nowadays to know that the treatment usually works. So one doesn't have to do the radiation if there's a tumor in the vertebrae like that. But if there's worry, then a short course of radiation therapy is not going to be harmful to the rest of the body. And one little area of the bone being radiated is not going to be enough damage to the healthy bone marrow to cause a problem in the future. So sometimes it's better to err on the side of caution and fix the area that might be a problem and then tackle the rest of the disease. But it is a judgment call. It depends on how nervous you are about that one spot in the spine.
So none. Okay.
Thank you, doctor. I have a question here.
With reduced kidney function, my doctor recommended a lower dose of Zometa. Have there been any studies done on the actual dosage level, whether you need 4 milligrams, whether it's beneficial to get 2 milligrams, or exactly what the impact of the dosage is?
So, good question. Reduced dose Zometa with abnormal kidney function.
So that's another very good question. There was a study with Iridia, and they used 30 milligrams of Iridia and compared it to 90 milligrams of Iridia, and it actually didn't seem to make a difference. The Zometa gets 50% of it or thereabouts gets eliminated by the kidneys. So if the kidneys are not working as well, presumably less would get eliminated. So a slightly low, if you wanted to give equal doses for somebody with kidney problems and somebody without kidney problems, you would give a slightly lower dose of Zometa to the person with kidney problems. Probably the most important thing with the drugs is causing harm is to give them slowly enough. Because it's the pace of the administration of the drug that seems to be the important, and also not getting it when somebody comes in dehydrated. So I've had one person a long time ago that after the infusion, her creatinine bumped quite a bit, and in retrospect, she had some kind of gastrointestinal problem, and she was dehydrated, and she got some Iridia, and that was a bad combination for her kidneys, and she had a bump in her creatinine. So that may be the most important of all.
Okay, that's good. All right. Okay.
Any connection between Paget's disease and multiple myeloma? If you've had Paget's disease for a long time and you also develop myeloma?
Interesting. So Paget's disease is a disease of bone, a metabolic bone disease. Is it linked to myeloma?
Not that I'm aware of. No, not that I'm aware of.
We do use bisphosphonates to treat both, however. So it's lucky that bisphosphonates would treat both.
Right.
Paget's disease is actually very, very sensitive to bisphosphonates.
I think there was a study years ago where they compared Fosamax to a single dose of Zometa, and the single dose of Zometa was superior to the typical Fosamax dose at helping people with Paget's disease, to kind of give you an idea of the potency of the Zometa compared to the Fosamax.
Okay,
Right here.
okay.
If you don't have bone disease, do you still need Zometa, and how often?
Okay.
That's a really good question.
They get these questions teed up for you, Bob.
That's a good one.
And we have a stop
yeah,
sign back there, so in 20 seconds or less?
I think it's unclear. I always would do a bone density test, and if it shows osteoporosis or severe significant osteopenia, then I would err on the side of giving it. If somebody has no osteoporosis, no osteopenia, no bone problems at all, I don't know that you have to, and I think probably the general feeling is you don't do it, but, you know,
Maybe things are changing with the use of new techniques for the diagnosis of bone lesions, because in the past it was only standard X-ray, and now we have all those new imaging techniques which show that there are more people with non-visible bone lesion on X-ray and non-clinically relevant, but which still are here. So maybe the definition of the indication of diphosphanates will change.
Right, and so one of the big studies that suggested that maybe you should give Iridia or Zometa even if you had bone disease was the MRC study. Yeah. But as you point out, they were only using X-rays. So I think that they were underestimating the bone disease, and so I think that's what influenced that study. So I think that Dr. Vesio, he said 85% of patients have bone disease, 15% don't. And so if you would do more imaging, I certainly would be comfortable not to use the bisphosphonates if all of the imaging was negative. And, okay. Okay. Are we finished? Oh, okay. We're finished? Okay. Okay, I guess I think she lost her stop sign back there, and she's just doing something like this. I think we're done. All right. Thank you very much. Okay. So we're going to move into the last segment before the break, and before we do this, I'll mention two things. Number one, we did have the intent that Dr. Tom Martin from UCSF would be giving this talk, but he just was not available. He came to teach the Chinese doctors, but he just couldn't stay and be here for this afternoon. And so I'm going to introduce this idea of the new drugs and the approach to relapse, but we're going to have the panel come up so that you can get the opinions of Dr. Vesio and Jean-Luc about the new drugs and which of the new drugs look the most promising. So I'm just going to introduce this topic, starting with what should be the approach when it seems that the myeloma is relapsing, and then which of the new drugs are looking the most promising right now, and what does it look like in terms of getting approval from the FDA. So if we look at this chart right here, you can see that we really have been pretty fortunate in the area of myeloma, where if you go back into the 50s, 60s, 70s, 80s, and up into the 90s, there were not that many treatments available. We had radiation and melphalan and steroids. We had this VAD regimen, and then we had transplant. And this was the treatment all through the 60s and the 70s. And so it was only actually in the late 90s that we started to get more drugs becoming available. And the first of these novel drugs was thalidomide, which was tested in the late 1990s. 1997, 1998, we started to use thalidomide, which was approved. And then that's also when we were testing Iridia, and then also mini allotransplant. But then you move forward to the year 2000. So basically in the last 10, 15 years, you see this increasing list of drugs. These ones have already been approved. Velcade, Revlimid, and then more recently carfilzomib, pomalidomide, which is Pomalyst, and this high DAC inhibitor, that was panabinostat, which was the last one that got approved, kind of controversial actually, and we could talk about this. And then these are the 3 new drugs which have already been submitted to the FDA. So the results of the trials with elotuzumab, the anti-CD38, in this case it's the daratumumab, and then the oral proteasome inhibitor. So this is the drug which is like Velcade, and it's coming from the Millennium Takeda company, and this is called ixazomib. Don't ask me where they come up with these names. Ixazomib. So those 3 are in trials, and we're looking to get approval with those. So this is great, but one of the issues is that that's actually quite a lot of drugs, and as I said in one of the videos, it's important to know how and when to use all of these different drugs. The impact of those drugs has been significant, and you've seen these different charts. So with the introduction of these drugs, so in that same time frame, since the year 2000, the survival for myeloma, the response and survival has really been significantly increasing, and this is really tremendous. And that has been from a combination of stem cell transplant as well as those novel agents. So the approach to relapse is to assess the relapse. If the myeloma protein level is going up, or you have some pain or a new lesion, it's important to do some testing and figure out what would be the next best thing to do. And so what are those next best things? Well, as I've just shown you, it depends a little bit of these different new drugs, what has happened before. And so when we're trying to decide, will we use one of these new drugs, we really want to talk to you carefully and review the records to see, well, what happened before? If we gave you Velcade back over here and then you're relapsing over here, we would be thinking about, let's try some kind of a Velcade combination because it worked over here. If we gave you Revlimid and Dex and it did not work, and then you moved on to the Velcade over here, we might not be so keen to give you pomalidomide because that's a similar kind of a drug. We might be going to use Velcade or carfilzomib. So when we're talking about a relapse treatment, it's really, really important to review carefully what has been done before. Did you have frontline therapy consolidation? Did you have a transplant? And did you have consolidation or maintenance? At the point of the relapse, are you on maintenance or did you stop the maintenance? That really affects the choice. As several people mentioned, the Revlimid can hold you in remission, but obviously if you're on Revlimid, then that limits the choices at the point of relapse. You need to get to the next line of therapy after that. So the approach to relapse includes these things right here. It's extremely important to monitor the status of your disease. Initially, you're going in for testing every month, sometimes every week or even every couple of weeks. As you start on treatment, we want to be really sure if the treatment's working and what's happening with your blood count, your kidneys, all the chemical testing. So it's very frequent testing, and then it'll go to once a month, And then as you get further along, it's going to be every couple of months, every 3 months. We usually don't go much beyond that unless you're doing really well for many years. If the protein is going up or something is happening with your tests, we go back and look at what happened before and review that and see if one of these previous therapies could be used in some way or not. We would try to do that. Typically, we would try to use these combinations before we would immediately go to a new drug. Although sometimes with some of these new drugs, we heard the story about a gentleman who took daratumumab. Some of these newer drugs that we have right now are so promising that we might say, well, this other stuff did work, but the daratumumab looks really great. Maybe we'll give that a try, and then we always do have these other drugs to go back to. And so this is not a 100% statement right here. Maybe we will try some of those combos, or maybe we might go to a new agent. Something that has been touched on is that if you've had a fantastic response with transplant, and have been in remission for at least 2 years, but we have patients here who've been in remission for 5 years, maybe longer. If you've had a long remission and the myeloma is relapsing, we would definitely have a second transplant, what we call a salvage transplant, as one of the options. And so we would be looking at transplant in this situation as one of the options. So you could have transplant, you could maybe have daratumumab, you could maybe have elotuzumab, you could maybe have carfilzomib or pomalidomide. We're looking at these in somewhat of an equal way. Each one could maybe help you, each one could have different side effects, each one could be predicted to be helpful to a different degree depending on what's happened before. What happened before is really one of the most helpful things to us. The other thing is that when the myeloma is relapsing, much more frequently we want to keep you on therapy. So if you've been maybe off therapy and then the myeloma is bouncing back, that gives us some hesitation about stopping the therapy. And so much more frequently we'll say, okay, well, you're back in remission, but maybe we should continue with some maintenance. So that's what I mean here about continuous therapy. So those are major elements in deciding what to do at relapse. And of course, versus the standard approach, check if a new trial is available here in the Los Angeles area. And as you know, several of the different centers have quite a few trials available at City of Hope, at Cedars, UCSF, UCLA, and even up to UCSF in San Francisco. They really have a lot of trials there, which is why I'd actually wanted Dr. Martin from UCSF to be here today to talk to you. But I have a number of his slides, which I'll show you. So putting together these different combinations, we are looking at different classes of drugs. And so this is the way that we look at the treatment. So we're looking at steroids, and although steroids have a lot of side effects, frequently, especially at relapse, we'll add in steroids to try to get the treatment to work better. So for example, if you've been taking Revlimid by itself as maintenance, a first step might be just to add in steroids to get it to work again. Then we would look at combinations of bortezomib with steroids or bortezomib with thalidomide or Revlimid, and as I said, consider stem cell as a way to get you back under full control. And then, as for the evaluation throughout the disease, we're looking at how old are you, what are your risk of the cytogenetics. So if you have the 414, the 17p, all these things we've been talking about, that influences our choice more towards Velcade or carfilzomib, which seem to be a little bit better in the high-risk situation. If you have kidney problems, if it's an IV treatment, carfilzomib is a concern. You have to take carfilzomib Monday, Tuesday, each week for 3 weeks in a row. That's quite a problem if you have to travel, 2-3 hours to the infusion center. So we have to think about that versus maybe pomalidomide, which is by mouth and is a whole lot easier. Then it depends if your blood counts are low. If your blood counts are really low, that definitely can influence whether we would give you a high dose that would really knock your counts low. So all of these things, including what do you feel about the options, is obviously very, very important. So I've put together a list, and this is the list that we can talk about together, and then in a minute I'll be having the other doctors come up so that we can talk about what do we think about these new drugs that are coming and available now. And as you've heard, we are most excited about the anti-CD38, of which there's daratumumab and the SAR compound. And Dr. McHale is not here to pronounce the new commercial name for that. But anyway, I think it was something to do with pizza. So this is the SAR pizza, I think, here. Then there's elotuzumab, and then the anti-CD138, what are called checkpoint inhibitors. This is the new Velcade by mouth, and then a number of these other ones here. So I'm just going to touch a little bit on those to give you some flavor of what these involve, but each one of those do have a significant benefit in myeloma. So first of all, the daratumumab is the most exciting, and that's because it's active as what we call a single agent. Some of these drugs, they only work if you give them in a combination, but daratumumab works by itself. So if you give daratumumab, it works. Elotuzumab, I'll show you in a minute, if you give elotuzumab, it doesn't work. It makes Revlimid and Dex work better, but it doesn't work by itself, okay? So daratumumab has a direct benefit, and it also is dose dependent. So if you give a small dose, here you can see that we're getting partial remissions, which means that the myeloma dropped by 50%. However, if you gave double the dose, you can see here you got some complete remissions right here, very good partial remissions, so it's dose dependent. So, and now we know that we need to give this dose, and that's part of what we call the phase 1-2 testing to see which dose is the best. So it's dose dependent and works by itself. And this just shows you the trial using the different doses, the 8 milligram and then double the dose. And you can see the double dose is the red, and so if you look over here, this is the depth of the response. So if you have a VGPR, that means the protein drops by 90%. So you can see here, 90% is right here. So you can see there's a lot more red related to the deep response, so that if you give the higher dose, you get more, not only do more patients respond, but they get the deeper responses. And with the lower dose, you see there's more blue over this way, and then there were some patients who did not respond, so the myeloma progressed. The myeloma protein was going up here. But you can see most of the patients, it was either stabilized or in some of them, it really went down. And that's why this has been submitted to the FDA, and just with this one trial, we're expecting that the FDA will look at this favorably and maybe get some approval by maybe the end of October. And people are talking about this is going to be the Halloween approval. The other thing is, does daratumumab work in patients that are double refractory? And so that means, does it work in patients who have gone through like the Velcade, the Revlimid, all those previous treatments? And the answer to that is yes, because 95% of these people in these trials were actually double refractory. So it is able to rescue patients who've gone through those other therapies. So this is a very important part of these trials. And then the question is, how long does the benefit last? And so here you can see that the benefit is lasting, even those patients who've gone through everything is lasting about 4 months. And even more impressive than that is the survival, even for patients who have gone through everything, is really quite good. So it's able to keep patients going so that then they would be around to maybe need another drug later. So really quite a remarkable benefit. This is the results with the other anti-CD38. This is the one, the SAR compound, the pizza SAR. And you can see it's a similar pattern, maybe not quite as impressive. They haven't, for some reason, pushed the dose testing as much with this SAR compound, so we don't really know so clearly the impact with the 20 milligram dose. You see that they had a lot smaller doses. They had the 1 milligram, 3 milligrams, 5 milligrams, and they had much more limited testing at the higher dose. So there's more work to be done with the SAR. But when we asked at our working group meeting where we had 100 or so myeloma experts, the myeloma experts are certainly thinking that daratumumab is the one to be the most promising. 85% thought it was the most important. This shows you the results with the elotuzumab, and the trial for that was called the Eloquent 2 trial, and this was quite a large study where half of the patients, over 300 patients here, got Revlimid and Dex, and then the other half of the patients got elotuzumab plus Revlimid and Dex. And you can see that the length of the remission was significantly longer, over a year and a half versus a bit over a year, so significantly longer when you gave the elotuzumab along with the Rev-Dex. Both the elotuzumab and the daratumumab are given by IV infusion. Those are monoclonal antibodies. They have to be infused carefully over at least 1, 2, 3 hours, sometimes longer. And the main thing is because of allergic reactions and fever. With elotuzumab, the risk of the allergic reactions is fairly low. It was actually about 9% in this. With daratumumab, it was actually a bit higher, above 40%. And so one of the downsides of the daratumumab is these allergic reactions, which means that you might need to stay in the infusion center a little bit longer to get the IV. But you can see in this case that the remissions were quite good, and actually in this case, at 2 years, over 40% of the patients were still in remission. So really quite promising. Just to show you, this is a whole different idea. These are called checkpoint inhibitors. So this would be the tumor, this would be the myeloma, and then this would be the T cell that could be attacking the myeloma. And it's getting blocked. And so if you use a checkpoint inhibitor, it means that the T cell can start to kill the myeloma again. And this seems like it could be a helpful way to treat the myeloma, but those studies are in the early phases. This is the panobinostat, which is now commercially available, and I know there's 1 or 2 people in the room who are taking this right now. The results with the panobinostat were in combination with Velcade and Dex. So again, in this case, you need to use it as part of a combo, and combining it with Velcade and Dex, the results, I would have to say, were not super spectacular. Here you had a remission of 12 months versus 8 months, and a response of 60% versus 54%. So it was not so spectacular, although it was contributing something. And also the toxicity was kind of challenging, quite a bit. Diarrhea, not trivial, low blood counts. Look at this here. Really knocks your blood counts for a loop, and also quite a bit of tiredness. So this is not a trivial drug in terms of side effects, and not so spectacular benefit. And you can see here, patients obviously did better, the blue versus the yellow. In thinking about all of the different options, you need to look at that and then look at, well, what about using a combination of some of the drugs that are already approved? And so I've been involved in a study that we've been doing for the last couple of years or so, actually 3 or more years now, where we have been combining carfilzomib and pomalidomide. And so if you've gone through Revlimid and you've gone through Velcade, how about if you take carfilzomib combined with pomalidomide together. How does that work? Well, it turns out that that is actually pretty good. And we've seen high remission rates where the remissions have been lasting close to a year. And actually, the overall survival of these patients who are what we call relapse refractory is over 2 years. And so this has been a very successful, I would say, commercial backup. This is something that you can take using drugs that are commercially available. So a very effective option. At the opposite end of the scale, this has been in the news, is something that's called CAR T cells. And these are where you take the T cells out of the body, you play with them in the lab, and then you give them back, and they attack the myeloma against the CD19. And this is a very dramatic example. There were 5 patients in this study that were treated, and 2 of them, 3 of them didn't respond, but 2 of them had kind of a dramatic response like this, where they previously had a autologous stem cell transplant, and then here they were progressing again, and then over here you can see that they've had a sustained remission for quite some period of time here with very, very low levels of disease after getting these CAR T cells. So these are activated T cells which are killing the myeloma. This is only possible in 4 or 5% of myelomas right now, but there is an idea to expand this using different technology to be able to treat more kinds of patients. Then there was this crazy story about measles virotherapy. So how many of you heard about this in the news? Okay, yeah, so this was widely on the news. In fact, I think I've got it here. Yeah, I heard about it from the Star Tribune. This was the first I heard of it. It was in the newspaper. And people called me up to say, what did I think about the article in the Star Tribune? And I was like, oh, I don't get the Star Tribune. It's because it's published in Minnesota. This was a study that was published in the Mayo Clinic Proceedings, but actually the article had not come out yet. So the doctors had not seen the information yet. But this was the treatment results for 2 patients that they got IV of a huge number of measles vaccine vials. Now, in this case, the measles vaccine has been engineered to attack the myeloma. So when you get the measles vaccine, it doesn't cause measles. The measles, which is a weakened virus, is built up to attack the myeloma. So it's a whole new approach, which is called, it's got this word here, systemic oncolytic virotherapy. So this is a virus that will kill the myeloma wherever it is. And Dr. Stephen Russell right here, he calls this a one-shot cure. Yeah, because this one lady, she got the one shot, she got pretty sick, high fever for several days. She was in the intensive care unit, but all of the myeloma melted away. And so, as they say here, massive blast of measles vaccine wipes out cancer. And that's why I was getting, my phone was ringing off the hook. And this lady did fantastically well. About it appeared that the myeloma was gone. And this was fantastic because she had gone through every kind of therapy before. But after about 9-10 months, the myeloma came back, and she actually got a lesion in her skull right about here. And they treated that with radiation. And as I understand it, she's actually still in remission right now. And so this is a completely new approach that could maybe be very, very effective for myeloma. We don't really need to go through this, but basically the measles virus attacks through a CD46, so that it basically attaches to the surface of the myeloma, and it also recruits the cells around the immune cells to attack the myeloma. But it doesn't attack normal cells or cause measles. And now they have a bigger trial. So they have a trial which has been accruing since last October. We don't know the results of that, but it's ongoing. And they're actually now using a different virus called VSV, vesicular stomatitis virus. They have several plans in the work, but they're using a different virus which may be even more effective. So this is pretty exciting, although it take time to know. So just to summarize, and then we can take your questions for discussion, this is the top 10. I've gone through a number of them. There are also a number of others, different inhibitors and the like, and so it's really pretty exciting times in myeloma to see how all these different new therapies might work. And so we've moved forward from more options, better combos, longer remissions, and now we're looking at ways, really unusual ways, that maybe we could even start to wipe out myeloma, even in patients who have had a lot of previous therapy. So this is kind of the status of where we are. And I've moved the black swan. He's kind of in the shade here. I've got to move him back up into the light here. But anyway, he's currently hiding. Anyway. No, we don't. That's very, very important. So anyway, that's sort of an introduction, and so we'll be ready for questions. And I'd like that Dr. Jean-Luc Harasso and Dr. Bessie will come up so we can handle your questions about relapse and new drugs. Thank you. All right, questions?
But I'm going to wait for them to sit down. I'm going to be polite.
So you don't want me sneaking in some answers before they get there?
No,
in case
because
they
they're going to call you out on
I know,
anything that they
would
don't agree
probably
with.
contradict me. I know.
I never disagree with you, Brian, right?
Oh, no.
Sure.
Okay, right here.
So I picked up a fact sheet for an expanded access program for elotuzumab with Len and Dex out on the table.
Yes.
There aren't any California sites accepting patients. Is that likely to change?
Well, we certainly hope so. When these expanded access programs are put out by the drug companies, these are ways to try to get access before the drug is approved. So elotuzumab has been submitted to the FDA and probably will get approved October, November. So we're talking about a span of a few months here. And so because of the way that the IRBs work, the regulations of the hospital, they submit all the papers into the IRB. It can take a few months. So many times, by the time it gets through the IRB and the sites are up and running, they're getting the sites up and running, the drug is approved. So there's a small window of time. The other thing is that there are a number of issues so that you do get the drug for free, so that the elotuzumab is for free, but going in to get the elotuzumab is not for free. So that it's going to cost you, it takes, I think, for example, at City of Hope, they were telling me that it costs, I think, $250 an hour for the infusion. So it cost like $1,000. The drug's free, but it could cost you $1,000 to get the drug. So there are a number of issues in these compassionate use programs. And so that's why we, on the side of the IMF, we push really hard to get the approval when the drug and the infusion would be covered, okay? Yeah?
Suzanne.
Okay,
Go for
right
it,
here.
yeah.
My understanding is that in the case of daradutamab, sometimes it takes some period of time for the drug to start working.
Yes.
On average, how long does it take to start its effect if it's going to?
Were you thinking of any drug in particular?
The DARA.
Oh, the DARA? So either one of you want to comment about the speed of action for the DARA? Bob?
We had the opportunity to use it at Cedars, and I think it didn't, in our anecdotal experience of, less than 10 patients, it didn't, patients that were progressing really rapidly, sometimes didn't have enough time for it to work. Maybe it would have worked if they had time to achieve, get it for longer, but the disease was growing so fast that some people may not have had a chance for it to allow it to work. So
Yeah.
I don't know if it's the best drug if things are rapidly growing.
Right.
It's being used more now in studies in combination, so the hope also is that very quickly, assuming it's approved, it'll be approved in combinations where it makes a lot of sense.
Right, to use it in combo. So this is the gentleman over here who did take the daratumumab. How long did it take for it to work in your case? Yeah, you want to give him the mic? So you...
Okay. In my case, the results were almost immediate.
Okay.
On the trial, the first 3 months, I got it every week. So it brought the numbers down fairly rapidly, and I think almost immediately as soon as I started taking it.
Okay, so this is a variable, I think, for
Yeah,
some
it is
patients. So
variable.
what do you think, Jean?
I think what's interesting with daratumumab is first that it can induce complete responses in relapsed patients,
Right.
which is not so frequent with a single agent. And second, you showed the slide. Of course, when looking at the percentage of responses in double refractory patients, it's not that impressive. But double refractory patient treated by a single agent, it's really a challenge. So I think that these are two interesting points for daratumumab, which is certainly a great hope for the future.
Right, right.
Probably it will not be used as a single agent. It will be used
Right.
in combination with other agents.
So this is a really important point that Jean-Luc is making, is that for the trials, we have to satisfy for the FDA something that is called unmet need, which means that the patients have got to have gone through everything and then get the DARA as kind of a last resort. But of necessity, that means that probably we're not going to see the best responses in those patients. They may have very aggressive disease, and it's not a fair test for many of the patients, really. But that's what we need to do to get the approval through the FDA. Once we get the approval, we're going to be using it earlier, and we're going to be using it in combos where we'll get better results. Okay.
Okay, thank you, doctor. A question right here.
In your example about the measles vaccine, and this is not about measles, you mentioned the woman who had no more myeloma, but she got a lytic lesion.
Right.
And I don't understand that if the myeloma has pretty much disappeared, why you would get a lytic lesion? Is this a very naive question, or it just doesn't seem, it seems counterintuitive to me?
No, it's a terminology. They didn't report this MRD testing, so she had a complete remission by traditional standards, but I showed you the iceberg. I'm sure that she had a small number of cells left that seeded back into the skull. As Dr. Bessio was saying, some of these cells are floating around, and then an optimal area, they'll seed back in. So she had a small number of cells that were not wiped out. Yeah.
Question over here.
Okay.
You stated that daratumumab works by itself.
Yes.
Does this mean that we can say goodbye dexamethasone?
Well, I think that possibly. I mean, I think that obviously, I think everything works better with Dex, except your relationship with your wife. But I don't know. What do you think about that, Bob?
Well, I think, there's some drugs that we don't use so often anymore. Like, I don't know the last time I've given vincristine, so it didn't work very well, and it caused some side effects. So kind of as better drugs come along, then the less effective and certainly more toxic drugs will fade away. But dexamethasone, unfortunately, is still a pretty effective drug. So
right.
Yeah, won't be soon.
Yeah. So Jean-Luc, I know in the French IFM study, you focused on using Revlimid without Dex for the maintenance because you even thought that the Dex could have some negative impact. Is that right?
Absolutely, yeah.
So maybe it could be a way to go. The Dex can interfere with the immune system, and so it's possible that, you know, dex-free could happen.
Question over here.
Hello. Maybe I am asking this question too quickly. I had measles, but my grandfather died of measles.
Okay.
And I was wondering if I ever get the option to get a measles injection, if I should consider it even.
Okay, this touches on an aspect that I showed, but I didn't really comment on it. So we mostly all had measles vaccination, okay? So that means that we mostly all have measles antibody in our blood. So if you give this massive dose of the measles vaccine, it will be attacked by the antibodies in your blood, and it will never get to the bone marrow to attack the myeloma. And so these patients who were treated and who responded, they had low levels of the antibody in the blood, which allowed them to be treated. And that's the reason they've actually switched to this other virus, which is VSV, where there are no antibodies in the blood. So the application of this measles vaccine is limited to patients who have low levels of the measles antibody. So strangely enough, do not get a new measles vaccination, because then that'll mean that you won't be eligible for this trial. By the way, when they opened that phase 2 trial at Mayo in October, there were over 2,000 patients that signed up for that trial. Just
Right here.
When I was looking at the 10 therapies that you had put up,
yes,
it seemed like maybe only 2 of them were immunotherapies.
Yes.
And I'm wondering, because so much effort, it seems like in the myeloma community, is about knocking down the immune system.
Right.
And to have a successful immunotherapy drug, you have to have a healthy immune system to harness to attack the target that you're trying to attack. Does that mean that there are some group of myeloma experts who are campaigning for strengthening the immune system so that these immunotherapies have a better chance of working?
Right. Well, I think that there's a whole new area opening up, which is called, and I didn't know what this is, but it was called IO, which is immuno-oncology. And the BMS company, they came to my office and they said they wanted to talk about IO, and I was like, IOU? Or what is the IO? It's, yeah, immuno-oncology. And so they're really fired up about this, all different things targeting the immune system. And so it is a new area for us. But I think that for me, the main way to improve your immune system is to get rid of the myeloma, you know, and then it'll...
You're right. I think that it's a strategy which has not been very successful in multiple myeloma because the immune system is not good from the beginning due to the illness, due to the disease, but also due to the treatment.
Yes.
But nevertheless, I think that this approach is becoming more and more attractive, and we have examples in oncology, especially with the treatment of melanoma and of lung cancer with the anti-PD-1 and anti-PD-L1, the checkpoint inhibitor that Brian showed. He showed a slide about that. So the oncologists have a very brilliant result with the anti-PD-1, especially anti-PD-1 in melanoma patients and lung cancer patients. So it's also a great hope for multiple myeloma, although we need more data before being...
right. So that, I mean, in melanoma, what they did is they actually used a combination of 2 checkpoint inhibitors. They blocked both sides of that arrow, the PD-1, the PD-L1, and with the combination, they actually had dramatic results in melanoma with the increase in the T cells killing the melanoma. So, but it doesn't seem to be quite so simple in myeloma because the immune system is definitely damaged. So we have to see. Okay.
We have a question over here.
All right.
Are there any elotuzumab trials with Velcade and carfilzomib, and would you expect the same kind of complementary benefit for that class of medication?
Okay, good questions. I think actually both were presented at ASCO, as a matter of fact. I don't know, you guys want to comment on that? With elotuzumab, the results with the proteasome inhibitor as well with Velcade were not quite as good. Synergy is best with the IMiD class. But I think that they tried it across the board. And this is very important in terms of the drug approval, where I believe they're trying to get approval that would allow the elotuzumab to be used as part of all the different combos, even although it mostly works with the Revlimid.
Doctors?
All right.
Going back to the lesion in the skull
Yes.
with that one lady, what happens to that lesion eventually? Because is it
Well,
like
she had radiation therapy, which I think and probably did completely wipe it out. So that lesion is probably gone for good, I would think, right?
Hopefully, in that particular
Oh,
area.
yeah, there you go.
I mean, the concept
this
is
is a firm medical opinion, hopefully.
The drug.
But say you have a lesion now, it has nothing to do with the treatment. Say there is a lesion right here. What's going to happen to it? It's not other bone break or anything. I hope not.
Well, wherever it is, it can still grow, and
It'll
if
grow.
you ignore it, then it grows deeper into and even can grow into the fluid around the brain. So it is an important area to fix. So the concept, what happened is the drug, the virus, the vaccine worked maybe in all parts of her body, but it didn't kill a few stragglers up in her skull, and those cells slowly, and in her case, she had more aggressive disease, rapidly grew, and so she was left with those cells that didn't die, and hopefully the radiation killed those.
But other than her, say you have a lesion and you have had, you're in a relapse, but you had a whole body scan done, and the only thing they found was a 5-millimeter lesion in the skull. What are they going to do to it? How do you treat that?
You might, you might give it radiation, or it might be an indicator of relapse, and you might restart therapy possibly. The main thing about the skull lesions, which is kind of odd, is that they affect the skull, but very rarely do they penetrate in, which is great. They will just expand in, and so if you radiate them, usually there's not any associated brain damage. So this is a really fortunate thing, is that they're usually not a problem.
Okay.
All right.
Guess what time it is?
Okay. Well, thank you very much.
Jean-Luc, don't go far. I'm going to ask you to do something. So, before you go to your break and then your breakouts, it is time for the raffle drawing. However, I really encourage some last-minute frenzied selling because these raffle tickets have funded research grants. So that $20 goes a long way, not to mention the beautiful gift from Tiffany's that 2 of you are going to walk out of here with. So come on, one last time, dig deep, last-minute frenzied selling. We've got operators standing by, staff standing by to take your money, and it all goes to a good cause. So raise your hand if you want to do some last-minute frenzied selling. Yes. Come on, guys, come on. It's only $20, come on. You want the cure or not? You got to cough up the $20. You want the prize too, okay. All right, now Jean-Luc, where did you go? Jean-Luc, we need an honest man to come up and do the drawing. It's generally Bob Kyle, but Bob's not here, and quite frankly, I don't trust the 2 other gentlemen. So I'm going to need you to come up and do 2 drawings, the winning ticket. And in your lovely French accent, it sounds so much, but not yet. We don't have all the tickets. Okay. Oh, okay. Selma, we got 2 over here.